हैं जो आने वाले हैं। उससे पहले मैं क्योंकि टाइम कम है और बहुत सारे लोग हैं जिनको हमें सुनना है, जिनके जो एक्सपर्ट हैं उनके हमें इनपुट्स चाहिए, ताकि किस तरह हम एक रोड मैप तैयार कर सके मध्य प्रदेश के लिए कि हम कैसे सिकल सेल की जो इस चैलेंज है हमारे, उससे हम कैसे फाइट करेंगे और हम कैसे जीतेंगे। तो इसके लिए मुझे आप सब लोगों का सपोर्ट चाहिए। एंड आई एम रियली हैप्पी कि आई एम रियली थैंकफुल टू गौतम जी, जो कि उन्होंने अपनी टीम के साथ बहुत कम समय में आप सब लोगों को एक प्लेटफॉर्म पे यहाँ पे इकट्ठा किया। एंड NHM is always there to support you, to welcome you with your expertise, to help us to tackle this disease. So thank you all. I think we should start with the panel discussion in the second session.
Role of government and civil society, which is moderating by Dr. Pankaj Tiwari sir. Sir is technical program coordinator, Jan Swasthya Sahyog. Rest of our eminent panelists are Dr. Nishan Saxena sir, Dr. Sandeep Chopra sir, Ms. Valeha Nas, Dr. R.K. Nigam sir, Dr. Shikha Malik ma'am, Dr. Rajni Bhandari ma'am, and Dr. Rita Saxena ma'am. I would like to request all the panelists to take the mic, and now I hand over mic to Dr. Pankaj Tiwari sir.
हमारे MD मैम जल्दी ही आती होंगी और सभी वासा सर, रूबी मैम, सबको आई वांट टू गिव माय न्यू ईयर ग्रीटिंग्स और बहुत धन्यवाद करना चाहूँगा NASCO का और गौतम जी का हम सबको साथ लाने के लिए, क्योंकि सिकल सेल की जो समस्या है उस पर हम साथ मिलकर अगर काम करेंगे तो शायद बहुत आगे जा सकते हैं। समय की कटिबद्धता को देखते हुए मैं ये कोशिश करूँगा कि हम जो बातें रखना चाहते हैं, हमारे 6 पैनलिस्ट हैं, वो सब एक नियमित समय से हम अपनी बातों को रख सकें। तो ये जो पैनल डिसाइड हुआ, जिसमें आई विल बी स्पीकिंग सम पार्ट इन हिंदी एंड सम पार्ट इन इंग्लिश, आई होप मोस्ट पीपल आर एबल टू अंडरस्टैंड, बट थोड़ा ज़्यादा हिंदी रहेगा, मैं हिंदी में थोड़ा कंफर्टेबल हूँ। तो अवेयरनेस, काउंसलिंग, स्क्रीनिंग की बात हम इस पैनल में करने जा रहे हैं। और जो मेरा अनुभव रहा, वैसे मैं एक फैमिली डॉक्टर हूँ और मुझे पब्लिक हेल्थ में काम करते हुए अभी 7-8 वर्ष हो गए हैं। तो मैं मरीजों को, उनकी फैमिलीज को, कम्युनिटी को हो रहा कि काफ़ी सारा जोर हम इलाज पर, नए मरीजों को ढूंढने पर करते हैं, बट जैसे जैसे हमारी मरीजों की संख्या बढ़ रही है, हमें ये रियलाइज हो रहा है कि बिना जानकारी के, चाहे वो मरीज हो, चाहे वो उनके साथी हो या परिवारजन हो या समुदाय हो, कई बार हम काउंटर प्रोडक्टिव भी हो जाते हैं और हम व्हाट वी डोंट वांट दैट आल्सो स्टार्ट्स टू हैपन। सो हम ये कोशिश करेंगे कि हम इस सभी एंगल्स को समझ पाए। तो पैनल को शुरू करते हुए मैं बहुत प्रसन्न हूँ और ये जो जबरदस्त बात है गौतम जी के ऑर्गेनाइजेशन की कि उनकी टीम ज्यादातर सिकल सेल वॉरियर्स के द्वारा बनाई जाती है और वो सिकल सेल वॉरियर्स को हर एक काम में जिम्मेदारियां देते हैं। तो मैं रिक्वेस्ट करूंगा स्वालिहा जो हम सिकल सेल वॉरियर है, छिंदवाड़ा से हमको ज्वाइन की है, शी इज अ पार्ट एग्जीक्यूटिव मेंबर ऑफ NASCO आल्सो, कि वो थोड़ा सा जो उनके अनुभव रहे, कल मैं उनसे फोन पे बात कर रहा था तो उन्होंने बहुत खूबसूरती से मुझे बताए। तो अगर संक्षेप में वो थोड़ा बता सके अपने लाइफ जर्नी के बारे में और उनके चैलेंजेस, और इस पैनल से वो क्या जानना चाहेंगे कि she was talking about yesterday कि maybe this is something which I and my community would like to know. स्वालिहा।
सबसे पहले तो सर स्क्रीनिंग के बारे में बात करना चाहूँगी कि स्क्रीनिंग हमारे मध्य प्रदेश में बहुत कम लोगों की हो पाती है और ज़्यादा लोग करवाना नहीं चाहते, क्योंकि अगर क्राइसिस आते हैं तो लोगों को पता ही नहीं होता है कि उन्हें सिकल सेल है, तो वो इस वजह से करवा ही नहीं पाते हैं। कुछ लोग रहते हैं जो किसी भी डॉक्टर के पास जाते हैं, जितना समझता भी नहीं है कुछ डॉक्टर। मैं सिकल सेल वॉरियर हूँ, तो मुझे बचपन से ही मतलब सिकल सेल है, तो मुझे भी नहीं पता चला था जब तक मैं 8 साल की नहीं हुई थी, मुझे खुद भी नहीं पता था कि मुझे सिकल सेल है। जब हमारे छिंदवाड़ा में डॉक्टर JM श्रीवास्तव सर आए, उन्होंने इस चीज़ का टेस्ट करवाया, तब हमें पता चला कि मुझे सिकल सेल है और फर्स्ट टाइम उसी टाइम मुझे ब्लड लगा। उससे पहले किसी को नहीं पता था कि मुझे सिकल सेल है।
स्वप्निल जी जो है वो SBI में काम करते हैं और हमारे सिकल सेल वॉरियर हैं भोपाल के, तो वो अपनी कहानी बता रहे थे कि किस प्रकार लगभग 6 महीने वो कम्प्लीटली बेड रिडन थे और उनकी फैमिली ने उनको टेक केयर किया। वो अभी 3 साल पहले उनको हाइड्रोक्सीयूरिया वो चालू कर पाए। वो 40 वर्ष की उम्र के हैं और वो एक एजुकेटेड बैकग्राउंड से। तो हम ये समझ सकते हैं कि मेडिकल फ्रेटर्निटी में भी द डर्थ ऑफ अंडरस्टैंडिंग ऑफ सिकल सेल डिजीज इज ग्रेट, एंड दिस इज समथिंग व्हिच वी नीड टू एक्नॉलेज. We need to talk about it amongst our community, and we need to sort of let people understand how do we really want to work on this. तो इस चर्चा को आगे बढ़ाते हुए इस पैनल को हमने मोटा मोटी इस तरह से करने की कोशिश की है कि हम पहले अवेयरनेस और काउंसलिंग के विषयों पर चर्चा करें और फिर उसके बाद हम स्क्रीनिंग फॉर सिकल सेल डिजीज पर चर्चा करें, और लास्ट के 10 मिनट हम ऑडियंस के क्वेश्चंस और कमेंट्स और बाकी पैनलिस्ट के क्वेश्चंस कमेंट्स के लिए रखेंगे, तो आप प्लीज़ अपने नोट करके रख सकते हैं. तो मैं रिक्वेस्ट करूंगा मैम डॉक्टर रजनी भंडारी, जो अपने वास्ट अनुभव के साथ हमारे साथ जुड़ी हैं. मैम इज़ द प्रेसिडेंट ऑफ थैलेसीमिया एंड चाइल्ड वेलफेयर ग्रुप इंदौर. तो मैं चाहूँगा कि मैम अगर सिकल सेल से संबंधित अवेयरनेस से रिलेटेड जो सवाल हैं, क्या, क्यों, कैसे, अगर उस पर वो रोशनी डालें. मैम.
हेलो. उसके पहले मैं 2 बातें करना चाहूँगी. मैं पिछले 28 सालों से थैलेसीमिया और साथ में कुछ सालों से अभी पिछले 8 सालों से सिकल सेल के लिए भी एज ए सोशल वर्कर काम कर रही हूँ, और बहुत सारे पेशेंट, शायद 800 के करीब पेशेंट, उनको मैं पर्सनली जानती हूँ, उनसे मेरा इंटरेक्शन होता है जब वो चाचनेंद्र हॉस्पिटल में हमारे डे केयर सेंटर में आते हैं. डॉक्टर रविंद्र छापड़ा एग्जाम्पल हैं, वो अरविंदो में थे, तब से मैं उनको देख रही हूँ. तो मैं 2 बातों पे चाहूँगी कि सरकार ध्यान दे. थैलेसीमिया के ऊपर तो बहुत ज़्यादा अवेयरनेस हो चुकी है, लेकिन सिकल सेल अभी भी एक ऐसी डिजीज़ है जिसमें ज़्यादा अवेयरनेस नहीं है. तो जिस तरह से थैलेसीमिया डे मनाया जाता है 8 मई को, उसी तरह से सिकल सेल डे जो है, अगर युद्ध स्तर पर सरकार की तरफ से भी अवेयरनेस के लिए मनाया जाए और उस दिन सिकल सेल पे स्पेसिफिक प्रोग्राम किए जाएं, जैसे कि आप बता रही थी कि आप इतनी बड़ी हो गई और सिकल सेल का मालूम ही नहीं था और एक इतने बड़े पेशेंट को हाइड्रोक्सीयूरिया अभी शुरू किया गया, तो अवेयरनेस उससे बढ़ेगी. हमें कॉलेजेस में होर्डिंग्स लगवाने चाहिए, पेपर्स में पैम्पलेट्स रखवाना चाहिए. और जो मोदी जी का, अभी मैं मोदी जी से 14 नवंबर को इंदौर में मिली थी, जब वो इंदौर में रैली के लिए आए थे, तो मैंने उनसे पर्सनली कहा था कि आप मन की बात में एक बार सारे यंगस्टर्स को कहिए कि ब्लड टेस्ट कराकर शादी करें, जिससे कि थैलेसीमिया और सिकल सेल के जो इतने सारे पेशेंट पैदा हो रहे हैं नए, तो उन पर रोक लगेगी. में आप मन की बात में उनके मुंह से ये जरूर सुनेंगे कि सारे यंगस्टर्स को ब्लड टेस्ट करा के अपना स्टेटस रिपोर्ट, कहा गया है ना कि सिकल सेल कार्ड आपके पास होना चाहिए कि आप सिकल सेल चेक हैं कि नहीं, और शादी करने से पहले उस कार्ड की मैचिंग करनी चाहिए कुंडली मिलाने के स्थान पे. तो वो बहुत जरूरी है. दूसरा, अवेयरनेस हाउ एंड व्हाई. तो हाउ तो मैंने आपको बताया, ये चीज मैं हमेशा कमी महसूस करती हूँ. और दूसरा क्या होता है कि सरकार के जो प्रोजेक्ट्स होते हैं वो कागजों में ज्यादा रह जाते हैं और मरीजों तक नहीं पहुँचते. सिकल सेल के जो पेशेंट होते हैं उनकी 2 मेन प्रॉब्लम्स होती हैं. एक तो उनको ब्लड चढ़ाने की बहुत देर से जरूरत पड़ती है, और जब पड़ती है तो डायग्नोस नहीं हो पाता कि इनको ब्लड चढ़ाना है, और उनकी जो बॉडी एक हो रहा है बोन से डॉक्टर्स कि ये इसलिए हो रहा है कि इनको सिकल सेल की सीवियरिटी हो रही है. तो उस तरफ ज्यादा ध्यान दिया जाना चाहिए. और इसके अलावा जनरल पब्लिक में एक ये क्या कहना चाहिए, आदिवासियों में ये बीमारी बहुत ज्यादा है, और सरकार ने भी पायलट प्रोजेक्ट इसीलिए लिया है कि 8.6% जो हमारे इंडियन पॉपुलेशन है वो आदिवासी है, और स्क्रीनिंग सारे आदिवासियों का सरकार करना चाहती है. तो मेरा ये सोच है कि जो जनरल है आदिवासियों के अलावा, उनमें भी बहुत सारे पेशेंट में मैं सिकल सेल देखती हूँ, और मेरे पास जितने पेशेंट हैं 50 पेशेंट सिकल सेल के, उनमें से आदिवासी शायद कोई भी नहीं है, वो सब जनरल पेशेंट है. और मैं अपने एक पेशेंट का एग्जांपल कोट करना चाहूंगी. मिथुन उसका नाम है. वो 4 बहनों को तकलीफ होती है तो वो फौरन इंदौर आ जाता है. उसको जरा सा दर्द हुआ वो इंदौर आ जाएगा, जरा सा हीमोग्लोबिन कम होगा वो फौरन इंदौर में आ जाएगा, और जितनी बार मैं उसको बुलाऊंगी उतनी बार वो आएगा. वो लड़का 23 साल का हो गया और एकदम हेल्दी लोगों की तरह वो लाइफ अपनी जी रहा है. तो सबसे इम्पॉर्टेंट है फॉलोअप और काउंसलिंग। जो भी ट्रीटिंग डॉक्टर्स हैं उनको बराबर फॉलोअप के लिए पेशेंट को बुलाना चाहिए। हम फॉलोअप में हमेशा पीछे रह जाते हैं, ये मेरा सोच है। और जनरल अवेयरनेस, जिस तरह से हमने इंदौर में यूनिवर्सिटी में बहुत बड़ा सारा होर्डिंग लगवाया थैलेसीमिया अवेयरनेस के लिए, उसको पढ़ के कितने सारे मेरे को लोग फ़ोन करते हैं कि मैडम ये क्या है। तो उसी तरह से अब मैं यहाँ से जाके यूनिवर्सिटी में एक सिकल सेल पर भी लगवा दूंगी, जिससे लोग फ़ोन करके पूछेंगे मैडम ये क्या है और इससे कैसे बचना चाहिए। मुझे लगता है 4 मिनट मेरे पूरे हो गए हैं, इसके ज़्यादा आप लोग मुझसे ज़्यादा एक्सपर्ट हैं। मैं प्रैक्टिसिंग डॉक्टर नहीं हूँ, एज ए सोशल वर्कर आप सब एक्सपर्ट के बीच में ज्वाइन की हूँ। और गौतम को मैं थैंक यू करना चाहूँगी कि गौतम ने मुझे यहाँ बुलाया। थैंक यू सो मच।
जो कुछ बहुत महत्वपूर्ण बिंदु जो मैम ने टच किए, जिसमें उन्होंने कहा कि खासकर जो वर्ल्ड सिकल सेल डे के बारे में उन्होंने बात की, और ये शायद मुझे लगता है इंक्रीजिंगली अभी हम हर जिलों में अब ये प्रयास कर रहे हैं कि उस दिन हम लार्जर अवेयरनेस कैंपेन्स करें और किस तरह से उस एक इवेंट को हम यूज कर सकें टू ब्रिंग फर्दर अवेयरनेस। तो मैं अब रिक्वेस्ट करूंगा डॉक्टर शिखा मलिक, मैम इज एन एसोसिएट प्रोफेसर पीडियाट्रिक्स एट एम्स भोपाल, टू sort of also bring us further on what else can we add and do for the community to sort of bring awareness among them for sickle cell disease.
Mr. Gautam, who have invited us, and we have in such a short span of time we have had the state level conference, which is a very big thing to organize. So thank you, and also I would like to give my introduction. I am Shikha Malik. I am Professor and Head of Department of Pediatrics at AIIMS Bhopal. And before that I was working for maybe 17-18 years in Nadi Medical College before I joined AIIMS. And the journey started when I did my MD in 93-94. I was a 94 pass out. There were more children with thalassemia coming for blood transfusions than sickle cell. Of course, back then, as rightly said by Dr. Bhandari Madam, that it was more a disease of the tribal population. So out of so many patients that I saw during, and since my interest was also thalassemia, hemoglobinopathies and hemophilia, most of the patients belong to the tribal population. But rightly said that now whenever we are asking if there is a sickle cell disease patient, and they are, it's very likely that they do not belong to a tribal population. So this myth, when we are talking about tribal health, has to change. We always said that this is one thing which is linked to it, and there is like a 8.6 or 10. This is a 2011 census which says it is an 8.6% tribal population. But now, since the population of India has also increased, so has the number of tribal population. Awareness, I think, should start from home. If you target the homes, if you target the community, if you target the schools, the colleges, the sub-health centers, the PHCs and the CHCs, and of course there are now Ayushman health and wellness clinics which we have throughout the country, which is a huge number in itself, probably 1 lakh. Then there are of course the other district hospitals, medical colleges, media, schools, colleges and all those things. So when we talk about the rural health and the awareness, our Anganwadi workers, ASHA workers, Women and Child Development Department, Health Department, and so many schemes are there which are actually doing their part. But as of today, when I started my journey as a pediatrician, there was no hydroxyurea. As a PG student, we would buy empty capsules, and since there was no preparation, or it was just 500 milligram or 600 milligram, we would used to divide it in the capsule. And now probably it has become more available. But as of now also, with all these efforts that we did in 2014, probably NHM only launched on 1st of Feb for the pan state that they would provide hydroxyurea. But I'm sure it is even today not available at all the centers, which is one simple thing. So when we think of treating, of managing, of screening, of maintaining their health, one basic thing which is hydroxyurea is still not available. I use doctors also, so they can also be well trained. And see, we are training them. But what happens after the training? I mean, not even 5 or 10% people actually do what they have been trained for. So one is to ensure that trainings and retraining is about it. I think our school teachers should always, why not a chapter on sickle cell disease and hemoglobinopathies? I mean, it is becoming such a disease which is actually increasing the burden of disability in the country. You may maintain a sickle cell patient, but look at the number of sudden deaths in sickle cell disease patients. Though they are maintaining good health, you don't know what age there would be a sudden demise. So in spite of having few people who are maintaining a health, it is very difficult to increase their longevity, to give them a very good lifespan, to give them a healthy lifespan, because that is the need of the hour, that these patients who have got chronic illnesses, they have not been identified. And you know about it starts from Gujarat, Rajasthan, Maharashtra, Madhya Pradesh, Chhattisgarh, Odisha, Jharkhand, Uttaranchal. So this is a complete belt. So why not start from these states like Maharashtra did? It did screening of all their school children in Mumbai. Still, I don't know Penn State they have done or not, but what we need is all our adolescent girls, boys, which they say screening till 18 mandatory, and then आपके cards होने चाहिए. Pre-conceptional counseling, prenatal counseling. Suppose a child is born now with SCD, what to do? Nobody is aware. Then half of 95% of patients who are coming and you tell them this is sickle, they are not aware what this disease is. So that is what the awareness will cause. They will cause more of this thing. Having chapters in the book, having at least a test at school time admissions, immunizations we are already doing. Why not one simple card test at the time of admission? Though we are saying we are doing a card test of all the population, I mean they are not even aware. So these things at state level have camps in different hearts, in the melas, in the exhibitions, more in epidemic areas where the numbers are very huge, but also in lesser known areas. Because now it is not only concentrated to these states, it is going pan-India, and you will, I mean, the numbers are going very, very high. We don't know, this is a tip of an iceberg because we have not seen other cases, or we have not actually done any investigation for people whom we think do not have sickle. So the numbers may be huge rather than just limiting to a tribal population with a 1 or 8.6%. So that is there. Then very good thing is to have the Nehru Yuva Kendra indulge into this. They have the highest number of government servants pan-India. You can utilize their services like they are doing for tuberculosis. They can also do for sickle cell. It is I mean, I was also not aware of this, but when I met someone from the Nehru Yuva Kendra, and they said that the entire India, you total all the employees, that is the strength of the Yuva Kendra, social workers, or the youth. So we can utilize their services, but the time has come where the medicine should be available, the awareness should be there, the medicine should be available, the prevention should be there, and of course the penultimate or the ultimate thing where we go for a stem cell transplant. AIMS Bhopal, Dr. Sachin is here, Dr. Bhavna Dhingra is here, they are all in the committee for stem cell transplants, and it is just about to begin. And with the Honorable Governor of MP giving us funds for the Center of Excellence for hemoglobinopathies and rare diseases, probably it is next in line. But I feel that it will only cater to few patients. We should also extend these facilities to other specialist centers of medical colleges and all. So that is my take, and I'm very sorry why I have taken so much of time, but I'm really concerned. Because when we saw a small number 30 years back, and 30 years later, we are seeing the numbers growing exponentially. So now we have every one of us, of course this is a state conference, but I think there should have been more number of people involved in it, so that more number of people know and they are aware of it. And only your presence here, I mean the important people, most of the elite people who actually are the people who have done so much of work, Madam from Maharashtra. I mean, I've just heard her, and I know she has done 1,500, 2,000 cases of sickle patients. She has a huge experience. Now, I think all of us should begin with something huge, something big. Thank you so much.
लाने की जो बात है वो अब कई क्वार्टर से आ रही है और मुझे पूरा विश्वास है कि इसको डिपार्टमेंट सुन रहे होंगे और हमें पूरा विश्वास है कि ये बदलाव भी जल्दी ही आएगा, बिकॉज ये काफ़ी ज़रूरी बात जो आपने इसको यहाँ पर एम्फसाइज किया, जो कि अवेयरनेस में बहुत मदद करेगा। लेकिन इसके साथ ही मैं और जिस तरह से आप नंबर्स का आपने बात किया और जिस तरह से नंबर बढ़ रहे हैं, क्योंकि वो एक्चुअल में अनडायग्नोज थे, पता ही नहीं थे, डायग्नोसिस हो नहीं पाता था। हमारी मैं जन स्वास्थ्य सहयोग के साथ काम करता हूँ, हम लोग मध्य प्रदेश के परिधीय जिलों में काम कर रहे हैं। अभी अनूपपुर जिले में लगभग 1500 सिकल सेल डिजीज के मरीज हैं और डिंडोरी में 1000 सिकल सेल डिजीज के मरीज हैं और वो नंबर और बढ़ रहा है। अभी तो सब लोग का स्क्रीनिंग नहीं हुआ है, तब ये है। तो मतलब संख्या बहुत अधिक है, वॉल्यूम बहुत ज्यादा है, हम कैसे उनके लिए एक उपयुक्त केयर दे पाए ये एक चैलेंज है। लेकिन इसके साथ जो बहुत ही एक बारीक बात जिस पर मैं चाहूंगा डॉक्टर निशांत आगे इसको लेके जाएं, कि अब ये हमारे सामने एक मॉरल एथिकल क्वेश्चंस भी बहुत आ रहे हैं, जब हमको पता है कि अब हमारे पास ऐसे सिस्टम्स हैं जो तेजी से डायग्नोस कर सकते हैं, एक कॉस्ट इफेक्टिव मैनर में डायग्नोस कर सकते हैं। तो हम किस तरह से किस स्पीड से स्क्रीन करें, और जब हम स्क्रीन कर रहे हैं और लोगों को ये पता चल रहा है कि उनको या तो वाहक है या वो बीमार है और इससे उनके जीवन में क्या असर हो रहा है, फिर हम ये भी बात कर रहे हैं कि अगर आपके शादी करने के पैटर्न्स में बदलाव आएगा तो शायद आगे आने वाले समय में सिकल सेल जीन ट्रांसफर में बदलाव आएगा। बट ये सारे मामले बहुत सामाजिक मामले हैं, क्योंकि समाज बहुत कॉम्प्लेक्स है, वो बायोमेडिकल तरीके से सिर्फ नहीं सोचता, ना हम आप सोचते हैं। और तो मैं आई एम वेरी ग्रेटफुल दैट डॉक्टर निशांत हैज टेकन आउट टाइम। डॉक्टर निशांत सक्सेना जो है, हम दोनों लोग सेम शहर से हैं, इलाहाबाद से, ये मुझे अभी भी पता चला। और तो वो एक सोशल साइंस बैकग्राउंड से हैं और उन्होंने खुद मुझे कहा कि मैं इस विषय पर जरूर बात रखना चाहूंगा कि how do we actually, when we are talking about awareness, screening, how do we really do appropriate way of actually working with social groups? So I'll request Dr. Nishan.
For screening 10 to 40 years, it has a different dynamics altogether. So you will be having people in the 10 to 19 age group when they are adolescents and they are like growing up. Then the young adults from 18 to 22 year age group, and then the married couples. So like if we are talking about the tribal people, वहाँ पे तो मैरिज 16 साल की हो जाती है, 15 साल में हो जाती है, तो वहाँ पे 16 साल से लेकर 45 साल तक के लोगों को आपको काउंसलिंग करना है, उनको समझाना है कि ये क्या है डिजीज, कैसे होता है और इसके लिए हम क्या क्या कर सकते हैं. So there is a whole lot of information which needs to be translated or transferred from us to the people so that they get aware and come out and screen. I think and also because India is primarily a rural population driven country, जहाँ पे अभी भी 70% population rural areas में रहती है, 10-12% शायद ट्राइबल है, इसमें अभी एग्जैक्ट फिगर नहीं पता, हमको लेटेस्ट 8.6 था पहले. सो उस 70% पॉपुलेशन के लिए क्या सोशल मीडिया एप्रोप्रिएट रहेगा कि हमें थ्रू टीवी रेडियो चैनल्स, कौन सा चैनल हम कम्युनिकेशन के लिए यूज करें, दैट इज ऑल्सो वेरी इंपॉर्टेंट. बिकॉज जो टारगेट पॉपुलेशन है हमारा, वो किस चैनल के थ्रू आपकी इंफॉर्मेशन रिसीव करके उस पर एक्ट करेगा, ये बहुत इंपॉर्टेंट है समझना. So what I think is that there is need of research on health communication for sickle cell disease as such. The next I am really grateful that Pankaj ji brought it out, is that about the culture. Because we are asking people कि आप अपने स्क्रीनिंग कराइए, and then there are issues of stigma in the community when people get screened, and also we want to counsel them. Like we were discussing, so I find counseling is a very Western concept. We don't go for counseling when we have issues in our daily lives. So how we expecting that people who are living in the rural areas or in the tribal areas, they will go out for counseling? So basically क्या होगा वहाँ पे, क्या CHO उनके घर तक जाएगा काउंसलिंग करने, या कौन उनको काउंसिल करेगा? आशा से हम बहुत कुछ एक्सपेक्ट करते हैं. This is my feeling. We have done some studies in areas where we were working on the malaria, और वहाँ हमने देखा कि आशा ने जब रैंक किया तो उसने बोला कि उसका 4थे या 5वें नंबर पे मलेरिया उसके लिए प्रायोरिटी है. सो आज की डेट में आप सिकल भी उससे करना चाहते हैं तो कितना उसको ट्रेनिंग चाहिए, उसको काउंसलिंग भी करेगी, वो अवेयरनेस भी करेगी, वो ट्रीटमेंट के बारे में भी बताएगी वो। सो ऑल दीज थिंग्स दीज हैव टू बी लुक्ड एट कि डू वी नीड समबडी मे बी एट अ क्लस्टर लेवल, कि शायद NHM ऐसा कर सकता है कि क्लस्टर लेवल पे जहाँ जहाँ पॉकेट्स ज्यादा है, जहाँ जहाँ हमको ज्यादा पेशेंट्स मिल रहे हैं, वहाँ पे हम डेडिकेटेड लोगों को रखें जस्ट फॉर दिस स्पेसिफिक पर्पस। एंड आई थिंक काउंसलिंग की जगह कुछ और वर्ड अगर हम यूज कर लें तो शायद बेहतर होगा, बिकॉज मेनी पीपल डोंट लाइक टू बी काउंसल्ड। एंड द थर्ड थिंग आई वाज थिंकिंग वाज अबाउट कोलैबोरेशन, बिकॉज दिस इशू विल बी इन्वॉल्विंग द हेल्थ sector as such, the community is there, and also we are looking at the rural or let's say the tribal population. Then there also the community we are talking, because I was yesterday reading the press note of the Press Information Bureau of India when last year the Honorable Tribal Minister introduced the mission. So they were talking about getting the tribal leaders on board. So how do we identify a tribal leader? Because tribes में तो बहुत सारे लोग leaders हैं, वहाँ पे religious leader अलग हैं, उसके अपने अलग influences हैं, वहाँ पे health tribal healers होते हैं, वहाँ पे उनके political leaders अलग होते हैं. So maybe they are talking about the political leaders, but I think we need to get the community as such on board, as well as the health worker and especially the frontline health workers. They need to be really trained and attuned to the cultural needs of the population where they are targeting. So these are some of my humble submissions. I think we should be looking at these 3 C's of sickle cell disease. Thank you.
Thank you so much, Dr. तक ये कला पहुंचानी होगी, और ये कला आसान नहीं है, इसमें बहुत समय और बहुत एनर्जी हमको देना होगा, जिसमें कम्युनिटी हेल्थ ऑफिसर से एक इम्पॉर्टेंट लिंक की तरह काम आएंगे। जैसे कि अभी हम उन पे स्क्रीनिंग का काम की जिम्मेदारी हमने दिया है, लेकिन जैसे उनको हाइपरटेंशन, डायबिटीज में हम कह रहे हैं कि वो फॉलो कर सकें, उस तरह से अगर वो सिकल सेल के भी जो अपने कैचमेंट के मरीज हैं उनके साथ कर सकें। और ये 3 जो उन्होंने कम्युनिकेशन, कल्चर एंड कोलैबोरेशन की बात की, ये एक बहुत ही सुंदर उदाहरण NASCO ने NHM के साथ प्रस्तुत किया है कि किस तरह से कोलैबोरेटिव तरीके से हम बेहतर केयर प्रोवाइड कर सकते हैं। और इसी बात को आगे बढ़ाते हुए मैं आई एम वेरी हैप्पी टू हैव डॉक्टर संदीप चोपड़ा जो DH झाबुआ से आए हैं, और हमारे जिला अस्पताल के जो उनके अनुभव हैं, जब मैं उनसे बात कर रहा था तो उन्होंने बहुत ही सुंदरता से अपने जो चैलेंजेस काउंसलिंग और जेनेटिक काउंसलिंग से रिलेटेड है वो बताए, और मैं डेफिनेटली चाहूंगा कि वो उस पर प्रकाश डालें।
देखिए मैम बता रहे थे, शिखा मैम बोल रहे थे कि हमको डोर टू डोर जाना है, और वाकई में हमने जब ये प्रोजेक्ट लॉन्च किया तो हम डोर टू डोर गए झाबुआ और अलीराजपुर में। जब हमने 15 नवंबर 2021 इस प्रोजेक्ट को लॉन्च किया था, तो डोर टू डोर जाके हमने इसको स्क्रीनिंग किया, और अराउंड हमने दोनों जिलों में मिला के 10 लाख पॉपुलेशन को स्क्रीन किया, जहां हमने अराउंड ये मान के चले कि 20 से 25 हज़ार हमारे पेशेंट हमने पॉजिटिव निकल के आया, और हमने फिर उसका इलेक्ट्रोफोरेसिस भी किया, और वहाँ से हमारा रिजल्ट निकल के आया कि अराउंड दोनों जिलों को मिला के ये कहिए कि 18,000 के आसपास हमारा ट्रेड निकल के आया, और लगभग 2,000 हमारे डिसीज निकल के आया। तो नो डाउट कि हम ये चीज़ कर रहे हैं, गवर्नमेंट इस चीज़ में आ रही, साथ में आ रही है। इन्होंने भी 2 जिलों को प्रोजेक्ट किया था, अब सारे जिलों को ले रहे हैं जहाँ ट्राइबल ब्लॉक है, वहाँ भी हम लोग ये चीज़ कर रहे हैं। अब हमारे पास हमने स्क्रीन कर लिए, हमारे पास डिसीज आ गए, नंबर ऑफ पेशेंट हमारे पास आ गए, अब हम क्या करें? तो हमने जो एक यूनिफॉर्म तरीके से हम उनको फॉलो कर रहे हैं, उन तक ट्रीटमेंट पहुँचा रहे हैं, जिसमें हमारे CHOs का भी रोल है, इवन हमारे डॉक्टर्स भी है, क्योंकि जब प्रोजेक्ट चला तो लोगों के बीच में अवेयरनेस अपने आप आ गई। अब एक किस्सा मैं सुनाना चाहूँगा कि मैं अभी स्कूलों में जा रहा हूँ, और वहाँ हम काउंसलिंग कर रहे हैं, स्टूडेंट्स को काउंसलिंग कर रहे हैं, उनको हम बता रहे हैं सिकल सेल के बारे में। तो एक चीफ गेस्ट आए थे, GOP थे, वो उसकी फैमिली खुद की उनकी सिकल सेल पॉजिटिव थे, उनको नहीं पता था कि मुझे मेरे बच्चों को हाइड्रोक्सी यूरिया देना है। तो जब वो आए, हमारी बातें सुनी उन्होंने कि हाँ जब वो मेरा लेक्चर उन्होंने सुना, तो उन्होंने अगले दिन मुझे फ़ोन करा कि नहीं सर, आप मेरे बच्चों के लिए भी हाइड्रोक्सी यूरिया भिजवाइए। तो अवेयरनेस डोर टू डोर हम जा रहे हैं, वहाँ से भी आ रही है, और हमारे जो रूटीनली हमारे जो प्रोग्राम हम ऑर्गेनाइज कर रहे हैं उसके कारण भी अवेयरनेस आ रही है। अब काउंसलिंग, तो हम काउंसलिंग भी कर रहे हैं, हमारे CHOs को हम सिखा रहे हैं, बट ये कहाँ, इस काउंसलिंग पार्ट के लिए हमको अभी CHOs को, हमारे आंगनवाड़ी को हमको ट्रेन करना है। इसके लिए मैं NHM से रिक्वेस्ट करूँगा कि ये प्लान करें आप कि काउंसलिंग पार्ट के लिए हम जो है आगे आए और इसको इनको ट्रेनिंग दें हम। अब जैसे आपने कहा था कि काउंसलिंग में हम क्या करें, मुझे लगता है कि हम 3 चीज़ों पे काउंसलिंग करें, प्री मैरिटल, मैरिटल एंड जो डिसीज आ गया उसको भी हमको काउंसलिंग करना पड़ेगा कि भाई आप आपकी जो रूटीन लाइफ है वो कैसे जियोगे। तो हमको तीनों सेक्टर में जाना पड़ेगा और तीनों सेक्टर में हमको काउंसलिंग नीड है। अभी जैसे मेरे पास जो पेशेंट एडमिट हो रहा है, डे केयर सेंटर पे जो पेशेंट आ रहे हैं, तो उनके जो पेरेंट्स हैं वो देख रहे हैं कि मेरा बच्चा परेशान है, तो वो आगे रह के हमसे पूछते हैं कि हम अब क्या करें। तो फिर मैं उन्हें पूरा जो है काउंसलिंग करता हूँ कि अब ये आपके बच्चे को डिसीज तो हो गई, लेकिन इसके संतान को ना हो, तो हम जो है बाकायदा हम जो कुंडली हमने हमारे सेंटर पे लगा रखी है उसके माध्यम से हम समझाते हैं कि आप ये इस तरह से आप ध्यान रखिए कि किस तरह से आपको शादी करना है और कैसे स्क्रीनिंग करवाना है। आपकी जो बच्चे की वाइफ या जो हस्बैंड आएगा उसकी पहले से ही, शादी से पहले ही आपको स्क्रीन कराना है। तो उस चीज़ के लिए अवेयरनेस आ रही है, मतलब जब हमारा प्रोजेक्ट लॉन्च हुआ उसके बाद में व्यूज अवेयरनेस आई, ऐसा नहीं कि नहीं आई है, आ रही है, लोग आगे रह के आ रहे हैं। काउंसलिंग हमारे पास खुद आगे रह के काउंसलिंग के लिए आ रहे हैं। ऐसे ही थोड़ा सा वीक हमारा है कि आफ्टर मैरिज काउंसलिंग, कि जिनकी शादी हो गई है तो उनको हमें एम्नियोसेंटेसिस, जैसे ANC हो गई है तो हमें एम्नियोसेंटेसिस प्लान करना है, DNA एनालिसिस प्लान करना है। हालांकि हमने स्टार्ट किया है बट हमारे सेंटर पे वो चीज़ है नहीं अभी, तो हमें सैंपल या मदर को ही हमको इंदौर भेजना पड़ा है, भेज रहे हैं, बट वो संख्या हमारी कम हो रही है, तो हम इस चीज़ में थोड़ा सा अभी वीक है, हमें वहाँ वर्क करना पड़ेगा। एंड डिसीज लेवल पे, तो डिसीज लेवल पे हमें मैनेजमेंट के लिए हमने डिस्ट्रिक्ट स्तर, जो जिला स्तर पे हमने डे केयर सेंटर बनाए हैं। तो डे केयर सेंटर पे जो है हमारे पास में नंबर ऑफ पेशेंट आ गए, क्या अवेयरनेस है, जो पब्लिक, जैसे मैं गुजरात से के पास में हूँ तो मेरी आधी से ज़्यादा जो डिसीज पेशेंट थे वो गुजरात जाते थे, लेकिन जैसे ही पता चला कि नहीं हमारे पास डे केयर सेंटर यहीं रन हो रहा है, तो अब वो बर्डन, मतलब मेरे पास 6 बेड है, 6 से मैंने 11 बेड करे तो 11 बेड मेरे फुल चलते हैं, एट ए टाइम मेरा लोड बढ़ा हुआ है। अब मेरी ये प्लान, मतलब गवर्नमेंट से रिक्वायरमेंट है कि हम ये सब सेंटर, मतलब सिविल हॉस्पिटल लेवल पे भी हम ले जाए और जो हमारे सामुदायिक स्वास्थ्य केंद्र है वहाँ तक हम हमारे डे केयर सेंटर को प्लान करेंगे। तो ये जो तीनों पार्ट में हमें काउंसलिंग को आगे बढ़ाना होगा।
थैंक यू डॉक्टर संदीप, थैंक यू। और तो अभी तक जो हम अवेयरनेस और के बारे में हम चर्चा करते रहे, इसमें एक जो चीज़ हमारे अनुभव में हमें समझ आया कि हमारा जो मध्य प्रदेश जिला है उसमें बहुत सारे ज़िले हैं जो अधिकांशतः रूरल, तो उन्हें एक सेट वर्क दिया जाता है जो उन्हें करना होता है, बट बहुत सारे ऐसे ज़मीनी स्तर की संस्थाएं हैं, छोटी छोटी संस्थाएं हैं, सामाजिक संस्थाएं हैं, यूथ ग्रुप्स हैं, जो एक्चुअल में उन्हीं कम्युनिटीज से होते हैं। वो ऐसा जरूरी नहीं कि वो स्वास्थ्य पर काम कर रहे हो सकता है वो स्पोर्ट्स में काम कर रहे हो सकता है वो कुछ और कर रहे हो, लेकिन वो लोगों को जानते हैं। तो हमें ये जरूर देखना चाहिए कि अगर हमें उस कम्युनिटीज को ये बातें समझानी है तो हम उनके साथ कैसे पॉजिटिवली इंगेज कर सकें। ये दिस इज आल्सो गोइंग टू बी ऑफ एक्सट्रीम हेल्प, सो इन्वॉल्विंग द लोकल लेवल CSOs, NGOs। अब इस चर्चा को थोड़ा सा और आगे बढ़ाते हुए, हालांकि हमने स्क्रीनिंग पर काफी सारी बातें मैम ने रखी और मैं बहुत क्षमा चाहूंगा मेरे अज्ञानता के कारण अगर मैं कई बहुत सीनियर डिग्निटरीज के सही नाम या डिजिग्नेशन ना बताऊं तो उसके लिए मुझे क्षमा कीजिएगा। कि स्क्रीनिंग जो है वो अपने आप में एक बहुत बड़ा मामला है और उसके अराउंड कई सारे चैलेंजेस हैं और उसको हम कैसे देखते हैं। तो मैं रिक्वेस्ट करूंगा मैम रीता सक्सेना जो कि इंटरनल मेडिसिन की प्रोफेसर हैं, मैम फ्रॉम GMC भोपाल, कि वो इस विषय पर प्रकाश डालें।
देखिए किसी भी कम्युनिटी में, सो दैट पीपल अंडरस्टैंड व्हाट इज सिकल सेल एनीमिया। मेरे पास जब कोई पेशेंट आता है और मैं बताती हूँ आपको डायबिटीज है तो उसको पता होता है डायबिटीज क्या है, पर उसको नहीं पता होता है कि सिकल सेल है। ये अवेयरनेस है। अवेयरनेस आपने क्रिएट कर लिया, but to achieve the mission of sickle cell elimination program, the most important step I feel is screening. So screen कैसे करना है? स्क्रीनिंग से हम समझते क्या है? स्क्रीनिंग इज ट्राइंग टू फाइंड आउट द डिजीज इन एसिम्प्टोमेटिक जनरल पॉपुलेशन. ठीक है, तो जब हम स्क्रीनिंग करेंगे तो हम कैसे कर सकते हैं? स्क्रीनिंग मास लेवल पे होगा, काफ़ी सारे लोगों का होगा, उनमें से कुछ डिजीज होंगे, ज़्यादातर नॉर्मल होंगे, एसिम्प्टोमेटिक पेशेंट्स होंगे. सो दिस कैन बी डन इन 2 ways. नंबर 1 इज यूनिवर्सल स्क्रीनिंग, कि आपने पूरी जनरल पॉपुलेशन उठा ली और सब में टेस्ट लगा लिया और देख लिया किसको सिकल है और किसको नहीं है. दूसरा है टारगेटेड पॉपुलेशन. सो इसमें हमको ये डिसाइड करना होता है कि कॉस्ट इफेक्टिव क्या है. किसी स्पेसिफिक पॉपुलेशन में स्क्रीनिंग करनी है, जैसे प्री एडमिशन, जैसे कि प्रेगनेंसीज, जैसे कि नियोनेट्स, या हमको पूरे जनरल पॉपुलेशन. तो ये इस चीज़ पे डिपेंड करता है कि डिजीज़ की बर्डन कितनी है सोसाइटी में. उन एरियाज़ में जहाँ पे प्रेवलेंस ऑफ सिकल सेल 15% के ऊपर है, हर 100 में से 15 व्यक्ति या तो कैरियर है या डिजीज़ है, वहाँ पे तो यूनिवर्सल स्क्रीनिंग ही रिकमेंडेड है. यू हैव टू गो डोर टू डोर, counsel everyone, tell them what is sickle cell, what is the benefit of screening and do the test. ठीक है, और जहाँ पे prevalence कम होती है वहाँ पे you can go for targeted screening. Targeted screening में हम कुछ population सब units को लेते हैं and we do the test in those population units. जैसे कि neonatal screening, हम सारे newborns की screening करेंगे so that we know who is the newborn born with the sickle cell disease, so that we can give him better holistic care in the future. दूसरी चीज़ चिल्ड्रंस में हम कर सकते हैं, जैसे हमने बोला एडमिशन से पहले स्कूल्स में, तो वो एक पॉपुलेशन हो गया. प्री मैरिटल स्क्रीनिंग इन यंगस्टर्स, इसके लिए अवेयरनेस बहुत ज़रूरी है. लोगों को पता हो, वो खुद से आए, आप उनके पास कैंप लगाएं तो वो आए स्क्रीनिंग के लिए, क्योंकि स्क्रीनिंग से पहले आपको कंसेंट भी लेना है. वो कंसेंट वो तभी देगा जब वो अवेयर है. ठीक है, फिर उसके बाद आप आ जाइए एंटीनेटल. एंटीनेटल इज कंपैरेटिवली इजी टू ड्यू बिकॉज दे ऑल गो टू द डॉक्टर एंड द डॉक्टर कैन काउंसल. ठीक है, सो एंटीनेटल स्क्रीनिंग की बड़ी इंपॉर्टेंस है. आप उन सब में हीमोग्लोबिनोपैथी के लिए देखिए, और अगर उनमें कुछ है तो उनके पार्टनर का भी टेस्ट करिए, एंड देन यू सजेस्ट प्रीनेटल डायग्नोसिस फॉर द फीटस. सो दिस इज अ वेरी इंपॉर्टेंट पॉपुलेशन. कैस्केड स्क्रीनिंग एक स्क्रीनिंग होती है जिसमें एक पेशेंट हमारे पास क्लिनिक में आया और हम उसको बोलते हैं भाई सारे भाई बहनों के टेस्ट हो जाएंगे, कजन्स के टेस्ट हो जाएंगे, कैसे ट्रांसमिशन होता है. तो जब कोई पेशेंट डायग्नोज होता है और उसको पता चलता है वो सिकल सेल है, तो ही इज़ अ वेरी रिसेप्टिव पेशेंट. आप उसको जो भी काउंसिल करेंगे वो समझेगा और वो उस चीज़ को, तो कैस्केड ट्रेनिंग इज कंपैरेटिवली ईजियर. तो ये कुछ चीज़ें हैं जो हमको करनी चाहिए उन एरियाज़ में जहाँ पे प्रेवलेंस बहुत ज़्यादा नहीं है. अब इनमें से कैसे करना है, what are the tests we can do for screening? The best test we all know for diagnosing sickle cell anemia is hemoglobin electrophoresis by HPLC या DNA testing, है ना. ये 2 मेथड स्टैंडर्ड है, पर ये कम्युनिटी में आप अप्लाई नहीं कर सकते क्योंकि बड़े बड़े इक्विपमेंट्स चाहिए, कॉस्टली बहुत है, सैम्पल प्रोसेसिंग इतना ईजी नहीं है, यू नीड अ ट्रेन टेक्निकल स्टाफ. सो जब हम स्क्रीनिंग की बात करते हैं तो वी रिजॉर्ट टू डिफरेंट सेट ऑफ टेस्ट. कौन कौन से टेस्ट हम कर सकते हैं? एक हम सिकलिंग टेस्ट कर सकते हैं जो हम कॉमनली करते हैं. सिकलिंग टेस्ट बहुत इजी है करना, इट्स कॉस्ट इफेक्टिव ऑल्सो. कम्युनिटी में कोई भी टेक्नीशियन कर सकता है, आपको डॉक्टर की ज़रूरत नहीं है. इंटरप्रिटेशन बहुत इजी है. तो ये सारी चीज़ें, रिजल्ट तुरंत मिलता है, दैट इज़ ऑल्सो वेरी इंपॉर्टेंट फॉर अ स्क्रीनिंग टेस्ट. तो आप सिकलिंग टेस्ट कर सकते हैं जब आप यूनिवर्सल स्क्रीनिंग कर रहे हैं. और जिनके भी पॉजिटिव हैं उनको फिर आप हेल्थ सेंटर पे कंफर्मेशन के लिए भेज सकते हैं विद सम डिफरेंट टेस्ट. अगर डिस्ट्रिक्ट हॉस्पिटल है तो हम HB इलेक्ट्रोफोरेसिस भी करा सकते हैं. अगर प्राइमरी हेल्थ केयर सेंटर है तो पॉइंट ऑफ केयर टेस्ट होते हैं जो हम कर सकते हैं. ठीक है, तो ये बहुत इंपॉर्टेंट है. और हमने फिर डायग्नोज किया, फिर क्या किया हमने, इन सबको हमने कार्ड्स दिए. कार्ड्स इज एक्चुअली अ वेरी ब्रिलियंट आइडिया. हाँ, तो कार्ड्स दिए, अब उसकी आइडेंटिटी बन गई कि वो सिकल सेल का कैरियर है या वो नॉर्मल है. वो एक आई कार्ड की तरह उसको कैरी करेगा. वो उसके प्री मैरिटल काउंसलिंग में भी हेल्प करेंगे. वो कार्ड्स हमेशा के लिए एक लेबल हो गए और इसका सारा डेटा आप ऑनलाइन अपलोड करते हैं सो दैट द कंट्री हैज़ अ डेटा. उसके पास, उसको कितने रिसोर्सेज उस तरफ वो करना है. तो स्क्रीनिंग इज़ वेरी इंपॉर्टेंट स्टेप लाइक दैट. दूसरी चीज़ ये है कि कुछ पॉइंट ऑफ केयर टेस्ट आ गए हैं. पॉइंट ऑफ केयर टेस्ट कार्ड टेस्ट होते हैं जिसमें आप एक ड्रॉप ब्लड डालकर यू कैन टेल कि सिकल सेल है या नहीं है. दे आर बेस्ड ऑन इलेक्ट्रोफोरेसिस. दे आर डिफरेंट कार्ड टेस्ट. मोस्ट कॉमन इज ऑन द बेसिस ऑफ इलेक्ट्रोफोरेसिस ऑफ द हीमोग्लोबिन. सो यू नो उसका स्टेटस क्या है, वो कैरियर है. इट कैन डिफरेंशिएट वेरी इजीली. सिकलिंग टेस्ट कैन नॉट डिफरेंशिएट बिटवीन कैरियर एंड डिजीज.
सो कंफर्मेशन बहुत ज़रूरी है उसके बाद। और पॉइंट ऑफ केयर टेस्ट में भी रिजल्ट आपको 15-20 मिनट्स में मिलता है, बट यू आर श्योर कि वो कैरियर है, वो डिजीज़ है या नॉन है। सो दीज आर द टेस्ट दैट वी डू फॉर स्क्रीनिंग पर्पज। Screening is the most important step. Once the patients are screened and they know their status, they are obviously more receptive for the counseling. They can understand the disease better. They will go and read about the disease. So these things are very important for elimination of sickle cell anemia.
क्या उस गांव में जाकर के उसने पहले कोई कम्युनिटी मीटिंग की है या नहीं? और एक कम्युनिटी मीटिंग करना आसान काम नहीं होता है। उसके लिए आपको पहले कम्युनिटी के लोगों, पंचायत के लोगों, आंगनबाड़ी के लोगों, उसके लोकल लीडर से बात करनी पड़ती है कि हम इस विषय पर आपके गांव में आकर के बात करने वाले हैं, और लोगों को जुटाना पड़ता है। क्योंकि जब तक हम बिना अवेयरनेस के, बिना इस प्रकार के किसी एफर्ट के वहां पहुंचते हैं, तो एक तो पहले लोग उतनी मात्रा में उपलब्ध नहीं होंगे, फिर जो होंगे भी उनको भी बहुत सवाल होंगे। और उस दिन जिस दिन आप स्क्रीनिंग करने जा रहे हैं, उस दिन आप पूरा साजो सामान लेकर के गए हैं कि आपको स्क्रीनिंग करनी है। उस समय आपका माइंडसेट अवेयरनेस या ग्रुप काउंसलिंग की ओर कई बार नहीं भी होता है। हालांकि हमें यूजुअली उसमें भी स्टार्ट करना चाहिए ग्रुप काउंसलिंग से, एंड देन वी शुड एक्चुअली गो फॉर स्क्रीनिंग। सो ये मुझे लगता है इसको हमको काफी एम्फसाइज करना चाहिए, बिकॉज स्क्रीनिंग टारगेट्स होते हैं, तो वी आर ऑन द रोल कि भाई हमको इतने लोगों को स्क्रीन करना है। दूसरा जो एक चुनौती आ रही है कि जब हम पॉइंट ऑफ केयर टेस्ट कर रहे हैं, तो पॉइंट ऑफ केयर टेस्ट, जैसे आप रैपिड मलेरिया का टेस्ट किया तो उसमें तो रिपोर्ट नहीं भी दी, तो क्या दिक्कत है भाई, आपको मलेरिया हो गया, मलेरिया दवाई ले लीजिए, गांव में कर लिया। अब आपने अगर रैपिड टेस्ट से आपने किट से टेस्ट तो कर लिया कि भाई उसको सिकल सेल डिजीज आ रहा है या ट्रेट है या नॉर्मल है, और उसे कहा जाए कि आपकी रिपोर्ट, अब आपको कार्ड मिलेगा लगभग 1.5 महीने बाद, तो ये भी एक चुनौती है कि इसको हमको कैसे सॉल्व करना है। Because for 1.5 महीने तक उसको, he doesn't have anything to show anyone that what am I? Am I a trait? Am I a disease? Am I what? So this is something which needs to be looked at. दूसरा ये भी कि क्या हम जब point of care testing कर रहे हैं, तो क्या हम consent forms ले रहे हैं? क्योंकि ये एक implicit understanding है कि हमने oral consent लिया है, हमने बताया है community को, but हम जानते हैं कि जब pressures होते हैं, तब लोग कई बार coercion power का भी इस्तेमाल करते हैं अलग अलग। तो फिर उसको बचाने के लिए क्या, कैन वी हैव सिंपल कंसेंट फॉर्म्स, सिंपल व्हिच एक्चुअली एक वे टू इंश्योर कि हाँ एक्चुअल में लोगों को बताया गया था कि हम क्या करने वाले हैं, व्हाट आर वी डूइंग, व्हाट आर वी टेस्टिंग फॉर, आर यू ओके विद दैट। सो दिस इज समथिंग व्हिच एंड, और एक तीसरी चीज जो मैंने मैम के सामने रखी कि किस तरह से हम, जो यूजर पोर्टल में एंट्री कर रहा है, चाहे वो सीएचओ है, वो एटलीस्ट अपना डेटा देख सके कि मैंने इतने लोगों की एंट्री की, क्योंकि जब वो अपना डेटा खुद का नहीं देख पाता तो उसे मिस्टेक्स दिखाई नहीं देती, जिससे कि मिस्टेक क्रिएट हो जाती है पोर्टल में। तो मैं बहुत बहुत धन्यवाद देना चाहूंगा हमारे सभी पैनलिस्ट का, ऑल ऑफ देम विद ग्रेट, यू वांट टू ऐड समथिंग सर? थैंक यू।
जैसा कि आपने
लोग अपना कैरियर डिटेक्शन कराएंगे। कैरियर डिटेक्शन कराने में एक बहुत बड़ी प्रॉब्लम ये आती है कि हम फ्री डिटेक्शन कैंप भी लगाते हैं, तो भी उसमें कराने नहीं आते हैं। पहले हम उनको पूरा दिखाते हैं कि व्हाट इज थैलेसीमिया, व्हाट इज सिकल सेल, वो सारा पढ़ लेते हैं, सुन लेते हैं। उसके बाद भी जब उनसे कहते हैं कि आके ब्लड टेस्ट कराओ, तो भाग जाते हैं, बिकॉज दे आर नॉट एट ऑल वेरी सीरियस अबाउट देयर हेल्थ। तो ये एक बहुत बड़ी प्रॉब्लम है। सरकार कब तक, कहाँ तक, किसके पास जा के करेगी? हमारी पॉपुलेशन इतनी ज्यादा है। तो मैं ये समझती हूँ कि अगर शादी के समय एक ये डॉक्यूमेंट भी सरकार कह दे कि होना जरूरी है, तो बहुत लोग वॉलंटरी अपना टेस्ट कराएंगे। इस बारे में मैं लिख के शायद सब जगह बार बार दे चुकी हूँ, हो सकता है कि आगे कभी इस पर सुनवाई हो जाए।
कि जैसे साइप्रस में हुआ है, बिफोर मैरिज दे शुड हैव अ कार्ड। आई थिंक दैट वी हैव ट्राइड एंड इट इज नॉट फिजिबल इन आवर कंट्री। We should try, and maybe after a decade it can be possible, but not today. We should try to assist.
स्कूल एंट्रेंस में हमें करना चाहिए, आंगनवाड़ी स्कूल्स हैं हर जगह, और ये जो ग्रुप फिर आइडेंटिफाई होता है, इनको समय समय पे काउंसलिंग करनी चाहिए, बिकॉज दे आर द पीपल हु विल बिकम एडोलेसेंट, हु विल बिकम यंग मदर्स, लेटर पेरेंट्स. So that is a target group where you should counsel, but screening and this thing at the time of marriage is sometimes not taken up there.
पुराने से हूँ, मैं सिकल सेल वॉरियर हूँ और नेस्को की एग्जीक्यूटिव मेंबर हूँ। और मैं आमंत्रित करना चाहूँगी डॉक्टर रुचिता पटेल को, जो कि कोलकाता से हैं और वो गुजरात से हैं, और वो भी सिकल सेल वॉरियर हैं, और इस कॉन्फ्रेंस में मेरी सहभागी है। ओवर टू यू।
Ruchita ji. National Alliance of Sickle Cell Organizations. To begin with, I am Dr. Ruchita Patel and I am a Sickle Cell warrior from Gujarat. Today we are gathered here to discuss the topic of roadmap for sickle cell disease prevention and management in Madhya Pradesh. We are starting to felicitations. I would like to invite Mr. Govt.of sir to felicitate Ms. Priyanka Das ma'am. I would like to invite Dr. Sachin Ban. Of NASCO, Neha, please over to you.
With the unity and anticipation, let's embark on this journey together. So here's to the new beginning, new challenges, new experiences, exclusive solutions, and a brighter and prosperous year ahead. I wish you all Happy New Year, and I'm delighted to welcome you to this very special program, which is proudly organized by the collaborative efforts of National Health Mission, SickleCell organization. Thank you.
और NHM MP का हम लोग शुक्रिया अदा करते हैं, साथ ही ICMR-NIRTH जबलपुर कि इन्होंने आज नेशनल किया और आज इस कॉन्फ्रेंस आप NHM और ICMR की वजह से ये हम लोग सक्सेस कर पाए। बहुत बहुत धन्यवाद। कॉन्टेक्स्ट सेटिंग में ऑलरेडी हमारा सेशन शुरू हो चुका था, तो हम सब यहाँ इकट्ठा हुए हैं वो सिकल सेल डिसीज़ मध्य प्रदेश से हम किस तरह से उसको ख़त्म कर सके जल्द से जल्द। हम 2047 तक रुकना नहीं चाहते, क्योंकि मैं भी 2 सिकल सेल बच्चों का पिता हूँ। साथ ही जो हमने नेशनल अलायंस सिकल सेल ऑर्गेनाइजेशन नेस्को को खड़ा किया है, उसके पीछे कारण सिर्फ यही था कि हम किसी तरह से इस डिसीज़ को किसी और के घर में ना देख पाए, क्योंकि यहाँ जो लाइन से बैठे हैं आने वाले ये 5-6 लोग सभी सिकल सेल डिसीज़ पीड़ित हैं, और हम सब जो नेस्को ऑर्गेनाइजेशन है ये पीड़ित और उनके परिवारजनों से मिलकर बना है। दूसरा, हमने भारत के 17 स्टेट्स में जो सिकल सेल डिसीज़ है वहाँ के ऑर्गेनाइजेशंस को इकट्ठा किया है और एक अलायंस फॉर्म किया है। अभी हम लोग मिनिस्ट्री ऑफ ट्राइबल अफेयर के सिकल सेल काउंसिल में हम लोग एज ए मेंबर भी हैं। ग्लोबल अलायंस सिकल सेल डिसीज़ ऑर्गेनाइजेशन के इसमें हम वोटिंग मेंबर के अलावा मैं एज ए वहाँ पर बोर्ड मेंबर भी हूँ, और मुझे मेंबरशिप कमेटी का भार सौंपा गया है, वहाँ का मैं चेयरपर्सन भी हूँ। इस तरह से नेस्को न सिर्फ डिस्ट्रिक्ट या स्टेट बल्कि हम लोग नेशनल और इंटरनेशनल दोनों ही तरफ से पूरे विश्व को सिकल सेल डिसीज़ को अवेयर करने के लिए अपने प्रयास कर रहे हैं, और इन प्रयासों को सफल किए हैं। उसके लिए फिर से मैं धन्यवाद दूंगा। आने वाले इस सेशन में आज जो 2-3 घंटे का टॉक है उसमें सिकल सेल अवेयरनेस, स्क्रीनिंग, ट्रीटमेंट, सारे इन पहलुओं पर जो हमारे देश के एक्सपर्ट्स आज MP में इकट्ठा हुए हैं वो अपने व्यूज़ देंगे, और उन एक्सपर्ट्स के व्यूज़ से हम ऑलरेडी जो मध्य प्रदेश है वो मेरे ख्याल से भारत में सबसे आगे है सिकल सेल डिसीज़ के कामों के लिए। तो हम मध्य प्रदेश से कुछ सीखने के लिए भी आए हैं, और साथ में कुछ ऐसी चर्चाएं हो जिससे और इस मिशन को किस तरह से आगे बढ़ाया जा सके उस पर एक फोकस हो। हम एज ए नेशनल अलायंस पेशेंट ऑर्गेनाइजेशन हमेशा से सरकार के साथ में हैं, और हम अपना पूरा सपोर्ट अवेयरनेस के लिए हम देना चाहते हैं। इस तरह के हम लोग स्टेट लेवल कॉन्फ्रेंसेस कर रहे हैं, ये 3रा स्टेट लेवल कॉन्फ्रेंस है। इसके पहले महाराष्ट्र मुंबई में हुआ, और उसके बाद हमने रायपुर छत्तीसगढ़ में किया, और अभी ये 3rd है, और आगे हम 17 स्टेट्स में हर कैपिटल में ये करने की हमारी इच्छा है, ताकि हम पूरे देश में सिकल सेल इस देश को जल्द से जल्द सिकल सेल बना सकें। और आज आप सभी लोग इस पर चर्चा होने वाली है, और कुछ हमारे जैसे पेशेंट्स के बेनिफिट की चर्चा ही होगी। तो उन सभी सिकल सेल पीड़ितों की तरफ से मैं पहले ही आप सभी लोगों का धन्यवाद देता हूँ, और थैंक यू सो मच।
We sincerely applaud you for giving a deeper understanding of our topic. Now I feel honored to have us with us, honorable guest, Dr. P.K. Batra sir. Sir is the Dean of GFC Group, Chhattisgarh. Sir will introduce us in brief on experience of sickle cell disease in Chhattisgarh. Sir, please, over to you, sir.
And all the dignitaries. I am thankful to the NASCO, especially Mr. Govt.of and his team invited me for the sharing my experience. I beg excuse little bit, I am not able to stay the meeting throughout as my flight is cancelled and I rescheduled from Indore, so I had to proceed and I had a meeting in Raipur in SickleCell. So I beg excuse for it. So in brief, I'll share my experience. Basically, I started my work in the SickleCell in 1985 when I was third year MBBS students with my professor medicine, Professor B.C. Kar, and Graham Surgeon in matter all aware of this fact. And since then I started, and when I joined in Raipur in 96, prior to that I was working as a medical officer in Sydney, in Madhya Pradesh, so that is undivided Chhattisgarh and Madhya Pradesh at the time. So I was a medical officer there, and I had a lot of sickle cell patients there, and I was feeling that helpless, so how to help them. So then I came to Raipur as assistant professor there and started working there. Then state divisions occurred, and 2007 we started a program that is the mass sickle cell screening. 2017 I screened the sickle cell there in Chhattisgarh with the only solubility test. So I request you all, please don't run after the very sophisticated test. Whatever this is available resources, you start doing. That is my request. And always don't look for the government. There are so many mandates. We have to do ourselves also. That is my another experience and request to you all, if you will sincerely help the sickle cell patients. Another thing, it is a very, as a worker, sickle cell worker, I feel very proud seeing you all and the NHM coming, that joining hands to do something for sickle cell. Because when I organized an international meeting there in Raipur in 2010, I was just hunting the speaker, national speaker, that time in 2010, and then Dr. the Bharat Ratna APJ Kalam was the chief guest, and then he was calling me as a sickle man. So and he just announced there in first sickle cell institute in Chhattisgarh, and it just came to reality in 2013, and fortunately or unfortunately I was the founder director there from 2013 to 2017. As a government servant, in 2017 I transferred to Bilaspur Medical College as a dean, but Dr. Chandak joined hands with me with CSIR, that project. So we do the screening work, and I continue, which is my passion to do the screening, because screening is very fundamental. I am not blaming any organization, but initially so many organizations were reluctant to do this sickle cell screening. क्या करोगे screening करके? Because it is a Mendelian recessive disorder. Only you have to go to the patient, because heterozygote will not complain anything. They will the only hidden the propagating as in these disorders. And you don't think as it is a very high ambition that government want to free the sickle cell in 2047. You mind it, this genetic disorders is this stage, it come to 70,000 years to come to this state, and it is not very easy to remove these disorders. This is a Mendelian recessive disorders. You have to be very practical and very hard. That is my another submission to the Augusta House and the government also. But I am very positive that the government is coming. Our Honorable Prime Minister is very hopeful and started the mission. Fortunately, I have the chairman for this direction of the how which method we do the sickle cell screening. So obviously I recommended for the point of care testing we should respect the technology part also, because I do all these tests in the solubility test. But it's not that I will confine to my, but at the same time I request you all, please don't run after any technology. The solubility test is enough to screen all these sickle cell patients, individuals. And another thing is, the sickle cell, there is no need of this sophisticated treatment. The 90% patients respond to this, the hydroxyurea and the folic acids. The other advanced treatments, they are very small. You should not be, हम तो बिल्कुल इसको काउंट नहीं करना चाहिए. Yes, because for every child, for parents, it's a valuable things. But for that, वो जो नॉर्मल घी होगा ना रहना चाहिए, वाली बात आ जाती है. So we should not be very fussy for that. हाँ बाबू हमको खाली जीन थेरापी चाहिए, स्टेम सेल थेरापी चाहिए. There is no need. We can have 90% patient with the hydroxyurea and folic acids. And the counseling is very important. Awareness is very important. When I started working in the Raipur, when I was going to the school for the village, they were snatching my car key. That क्यों चले आए? हमारे यहाँ stigmatization तो जैन मैडम बता रहे थे ना, stigmatization is a very sensible thing. You cannot say आप बता नहीं सकते. कोई एक आदमी को जो ओपनली एक इनक्योरेबल डिजॉर्डर्स में आप सफर करें, इट्स अ वेरी सेंसिबल थिंग्स, प्लीज माइंड इट. एंड उसको इतना ओपनली आप लोग बोलना नहीं. और इसको ये जो कार्ड कोडिंग के लिए भी मैं उसका अगेंस्ट हूँ, जो ये रिबिल्ड हो जाता है. तो इसीलिए मेरे जो कार्ड मैं देता हूँ वो कार्ड कोडिंग नहीं रहता है, बट इट कैरीज ऑल द इंफॉर्मेशन. बिकॉज ऑफ शॉर्ट ऑफ टाइम, if any times I can opportunity I can share detail of my work. और मेरा इतना ही रिक्वेस्ट है सभी को, एज ए वर्कर, सभी लोग आ रहे हैं, ये काम कर रहे हैं, ये मेरे लिए बहुत एज ए वर्कर बहुत ही सुखद क्षण है. और सभी लोग प्लीज काम करिए, खाली ब्लेम मत करिए किसी को, सरकार ये नहीं दे रहा, वो नहीं दे रहा, वो प्लीज मत करिए. मेरा इतना ही रिक्वेस्ट है. थैंक यू वेरी मच फॉर कॉलिंग मी एंड शेयरिंग.
Because I thought this will be useful for all the subsequent stages. Right, next page. Right, this is everybody, all are aware that National Sickle Cell Anemia Elimination Mission. This is very landmark decision by the Government of India, which has been announced initially by Finance Minister, subsequently by Honorable Prime Minister, particularly in Madhya Pradesh. And in this meeting, if you go through, he clearly mentioned the target of elimination by 2047. Because I am not going to talk about the possibilities of elimination, but it is a good move that government is committed for some kind of action. That is very important. But we are aware that it is not new for us, because the National Health Mission started working on sickle cell disease since long back. Next. And if you see the goal, I told already, this eliminate sickle cell disease as a public health problem, because we have to clearly distinguish what is elimination and what is elimination as a public health problem. Because there is a difference. Okay, subsequently when we get time we can discuss. Because elimination is 100% eliminate, nothing will be there, not like that. Right? Objectives is affordable, accessible and quality care, which is very important. We have to highlight that one, always that care is very important. And subsequently the prevalence of the disease will be reduced. Right? If you see the strategic pillars for this entire program is the primary prevention strategies, and subsequently for screening, then holistic management of continuum of care for the disease. Next. Right? If you see the implementation part, because nothing is happening very seriously, but both ministries, Health Ministry as well as Tribal Affairs Ministry are associated and they are working together. The reason is that the disease is a serious problem among the tribal population, right? And currently we targeted for screening some drugs right now. Right, what are the challenges? Because I would like to speak on two issues, challenges and opportunities. What are the opportunities for success of this program? Right, if you see that SCD is now a priority. Because earlier it was, because since few years back it was an academic topic in universities or medical colleges. People used to take for dissertations or master thesis like that. Okay. But a few places are there like Nagpur and other places in Gujarat. They, since long back they are working. Otherwise, if you see that mere screening is the only what you call haircut, because of course I am not I'm not against the screening, but only mere screening happened. Only screening was happened so far. But the unfortunate thing is simple screening and some kind of very sporadic campaigns of awareness is very dangerous. That kind of activities lead to stigma. Right? Always we tell that it is non-treatable disease, no treatment is there, your family members will get, your children also will get. This kind of knowledge gives a kind of stigma in the population. Right? That's about how to deal that we can discuss. Right? And the second, another challenge is health system is not prepared. We are all aware that even till recently, till the mission was announced, the NHM is also not so prepared, and also the peripheral level health system is also not prepared. So this is one of the challenges we have. And coming to the infrastructure, particularly the drugs and the workforce is also not enough for carrying these activities. These are all the challenges we have before us. And next, coming to the disease, epidemiology itself is a challenge for us because we have huge number of undiagnosed SCD, not SCD. I am not talking about the tribe, I am talking about the disease. Recently we surveyed in 6 states. Out of the people we screened as SCD, 85% are not aware of their condition. Okay. That doesn't mean that they are not getting the problem. They are getting the problems, they are getting symptomatic treatments. Okay. This is a big challenge. So we have to screen, we have to have a program for screening very systematically, and simultaneously we need to develop some kind of care programs how to deal with those patients. Right? Particularly, we are aware that this is highly prevalent among tribal population, as many people opine. We don't know that what about the other populations, because in fact we don't have much studies from other non-tribal populations, because maybe particularly Dalits and all also may be there. We don't know that one. Right? And also distinct health and the treatments in behalf of the tribal population. Because if you work in the tribal areas, because since my career I am working in the tribal areas, these tribal population don't like to go out of their territory for any kind of treatment. Because we tried in Visakhapatnam district to bring them to district hospitals. They never like to stay there. So we have to think that whether we can do something in their primary health centers, some kind of care. Because Madam can say that, Aditi Madam can, 90% of the population, patients need simple treatment like with hydroxyurea. Only very few numbers need the high level treatment which is available in the tertiary care hospitals. So we have to realize that. Next please. Then what are the opportunities we have? Because we have the NHM officials, they are aware that we have one of the best world's primary health care system in the country. Okay, we demonstrated that many large public health interventions were successful in this system. Because many people maybe particularly many groups may say that government system is not working, not good, not reaching. It's not true. We have to believe the government system. We have a massive PSA system in the rural areas. Right? That is a big opportunity for us to implement this mission program. And also nowadays we have Ayushman Bharat Health and Wellness Centers. It's a great opportunity for us because it is a revamped system of having new category of people like community health officer and new. Because if you see the new set of CPSC services, we have 12 services covering entire spectrum of diseases. Earlier PSC was only maternal and child health, some immunization. Right? Now it is not like that. We have entire set of services covering from non-communicable diseases to even trauma, palliative care, geriatric care, all are covered in primary health system. Right? So we have very revamped primary health system, which is an opportunity for implementing this program. And the health workforce also we have numbers are increased. Community health workers is a big strength for the system. and regular health workers like ANM and multi-purpose health workers. All these people are big strength for this program. And we have the laboratory network for across the PSCs and availability of expertise, because we are aware that we need not depend on any other country. Okay, we have enough expertise, we have plenty of hematologists, pediatricians, geneticists. Okay, we need not depend on any country like many other countries. And technology, we are leveraging the technology in the form of telemedicine and other. All can be the opportunities and strengths for this program. Next, please. Right? What is comprehensive care? Comprehensive care is beyond screening. Like many times I tell that ultimately the patient has to be benefited. Right? So screening is important. They follow in the form of either history or surveillance, whatever the mechanism is all important. Then treatment and care, then counseling and support systems, psychosocial support system is very important. Okay. We made a small experiment across the 6 states. Next please. Okay. By having these components like advocacy, inclusive partnership with different departments, capacity building in the primary health system, and community mobilization, which is very important, all together leads to SCD care. Next. Yet these components are very important. Health system capacity building is very important. Skill development, right from the community health workers to doctors and technicians at PSC or CSC level. And infrastructure development, like suppose if you want to screen at sub-center level with some solubility test or sickling test or now point of care test. Okay, infrastructure has to be improved, and PSCs definitely doctors should be trained, and medicine should be available, vaccination should be available, antibiotics should be available, because these 3 are required for the patients. And so this is one component that leads to screening at various levels. Of course, earlier we used electrophoresis, now we have the opportunity of using point of care, which is very easy to use. And treatment, we have hydroxyurea, it is well, because we have the studies saying that hydroxyurea is a safe drug, at least 90% of the patients can tolerate and can be used. And antibiotic prophylaxis, immunization, particularly pneumococcal vaccinations, and symptomatic treatment like pain relief drugs and all these can be implemented at PSC level. Right, registry kind of system should be developed to monitor as well as follow the patients, and referral systems like I told earlier that maybe less than 10% may need some kind of referrals like emergencies or blood transfusion and other complications. They can be referred to higher level hospitals, and particularly counseling and psychosocial support is very important in tribal communities that has to be developed. Because subsequently now we have started the mission with the screening. Maybe in the next stages we have to go to these steps. Next, please. Right, you guys right, next. Right, this is very important need of shift from screening to management and care, which is very important, because in long term we cannot say that screening may not add any credibility to the problem until unless you go for some kind of care. Right, whomever after 7 crore people, if you screen, definitely will have 7 lakh patients. Yes. Okay. What are you going to do with 7 lakh patients? We should be prepared for that. That's very important. Right? Involvement, because we have, I told already that ICMR-National health and wellness centers are coming. Already we have 1.7 lakhs of health and wellness centers in the country, so that we have to utilize those centers, and the NHM is very much aware of those, and there we need to create some kind of care for these patients. Okay, health system should be able to create hope that SCD can be treated and managed, because I say that, okay, don't say that, okay, by distributing some kind of cards that it is not treatable, it is lifelong disease, your children also will get, don't marry. These are the things which create some kind of stigma in the community. Rather you say that yes, it is treatable, we have the medicine, we treat, you come to a hospital. This kind of attitude is very important in long term. Need for providing care at PSC level with referral system, because I again and again argue that tribal population need treatment in their habitations. At least we can take them up to the primary health center. So they are very comfortable with their primary health centers. They have primary health centers in tribal areas have a lot of credibility because of non-penetration of private sector. Right? So we have to use these opportunities, and I hope that the mission will be very successful, and particularly the mission of Madhya Pradesh is always important, particularly with regard to hemoglobin status. I wish all the best. Thank you all.
We appreciate your enlightening.
Next slide, please. Now, I need not tell that why sickle is so important. We are having one of the largest population of sickle, and if we don't do anything, then the birth will go on. And the other map is telling you that when I started, it was just a small band coming from Gujarat, Central India to Orissa for sickle cell disease. However, now I think it is not the epidemiology which is changing, it must be we were not detecting them, because the other day I went to Rajasthan and I was surprised to see so many patients of sickle cell disease with, like it was managed. Even in Jharkhand, there are numerous patients there, Kerala, Telangana, many new states are reporting high prevalence of sickle cell disease. Next please. Now this would summarize, this is for Maharashtra. And in Maharashtra, sickle cell control program came in implementation in 2006. And then we had screened these states from 2018 to 2030. And now government has allowed us to use this data in the mission project as legacy. You must be doing. So this is the old 2008 to 2013 data, and we are continuing with the screening program and other things as mission sickle cell. Next please. Now this is just how we began in 1952, the first sickle cell report from tribal, and then as everybody is saying, which I always say, that also in non-tribal, which was reported in 1958. And so this 1958, the first non-tribal was reported in Chandrapur, which is very much near Nagpur. And after that there was a gap, not much done on sickle cell disease in India except Orissa, Dr. Kar. And then we at Medical College Nagpur started a sickle cell clinic with just giving them ORS and folic acid, just imagine, doing hemoglobin. That's how I started the clinic in 85. Then 92 we started giving penicillin from the cooperative study on sickle cell disease in US. Then we started, I think one of the main milestone in sickle cell is the tribal study, that is Jai Vigyan study by ICMR, which was done in 8 primitive tribals, and that came out with the solubility test, there is iron deficiency, many more facts. The other was in 2000 we started newborn screening for sickle cell disease. I think that was an eye-opener for me, and like others, even I made mistakes. I did newborn screening and I just gave them reports. Never thought that I should do something for SS. Okay, so it was only in 2002 I realized it's so wrong. Just to do, I was happy that yes, I could do newborn screening, but what is happening to the purpose of doing newborn screening? I think that is very important, which is not still done. I think so. We need to stress on few things. When newborn screening, very important, and it needs special expertise. It cannot be generalized for all newborns. They are all different. So that newborn screening and hydroxyurea first RCT, probably the only RCT is from Nagpur on hydroxyurea. We started in 30 patients, and there was a philanthropist who gave hydroxyurea, so we could do that. And since then we are giving, and since 2006 we are giving free hydroxyurea from government of Maharashtra. Another important thing, I think we are giving stress to mass screening counseling. For me today, the way to control sickle cell disease in our country is prenatal diagnosis. I think 17 states in Madhya Pradesh have compulsory antenatal screening for sickle cell disease. I read in the newspaper, 17 districts. 10 districts. I read in the newspaper. I was so happy. Because that is the only way we'll be able to. Ye shaadi nahi karna vagere, okay, they are coming up after 20 years of counseling. They are coming to me and saying, yes, ab hum shaadi nahi karenge vagere. But it's difficult. And they tell me, if your doctor is trait, will you tell? My doctor traits do not tell their to be wife that they are traits. Let me tell you, working with me. So it's not, you may be finding this very funny and ye kya bol rahi hai, but it is true. So I think prenatal diagnosis is the important thing, and neonatal screening. These two I would like to stress. And after that, we had a rapid progress, and now since 2018, Dr. Chandak is here. We are having CSR Mission Sickle Cell Project at Nagpur, and because of him today, I think in Maharashtra, I don't know about Madhya Pradesh, but then we are doing antenatal screening, but then who is doing prenatal diagnosis? In public sector. प्राइवेट में तो बहुत है, who is doing? And हम जैसे करते हैं इतना लोड आ जाता है थैलेसीमिया एंड सिकल सेल बोथ. So I think because of CSIR, we are doing free prenatal diagnosis for all patients. I think that is the only place, CSIR is the only agency doing free prenatal diagnosis in Maharashtra. I don't know about Madhya Pradesh, but I think that is one thing which needs to be stressed, because many prenatal diagnosis center and lab should be open, and they are always happy to support us. And I think now we have gene therapy, bone marrow transplant, which is not there in my center, and out of 100, 2 patients, 100 SS patients, 2 will, let me tell you, we all know that sickle is very heterogeneous. All are not severe. Only 20% would be severe. Of them, 2 will need bone marrow transplant. Okay? So we have drugs, like he said, we have drugs. And the other thing is, sickle cell in India is different. So it took me 3 decades to explain globally that sickle cell disease in India is different. We have high hemoglobin F. They think it's mild because of our area, Madhya Pradesh, Sydney, Chhindwara, the patients come to me and I know they are very severe. And Vidarbha, very severe. Gujarat, mild, maybe milder. But then this central India is very, very severe. That's what I would like to tell. But all are not severe, there may be mild. Now there is leg ulcers, priapism, which are not seen in Nagpur, but they are seen in Madhya Pradesh. So the clinical presentation is also very different even within India. So that is, I think, one thing which we need to know about it when we prepare for it. Now, incidentally, what happened was, Lancet Hematology comes with a commission every year, one commission. And in 1918, it was decided it will come on sickle cell disease. So there are 8 countries who were authors in this, all of us, and the first time India was represented. And these are different chapters which are there. Screening and prevention is given importance, and training, education, everything is given, and this is global, what is done everywhere, including India. And these are the key recommendations. However, this went into press on 31st of January 2023. And the Mission Sickle Project was declared on 1st February. So that part has not come into Lancet. That is very unfortunate that people will not know. So now they've asked us to write a review article on India, so we are writing it about it. Now I'm not going to repeat all this. Only thing I want to tell you is, here the word eliminate sickle cell by 2047. Yes. What do we mean by eliminate? Let us see. We are going to control a birth of a sickle homozygous child. I think that is what I think. That is what, do everything, screening, treatment, everything. But then my goal is, let us reduce the burden of sickle, birth of a SS child. That is the main purpose, isn't it? So I think we just keep on telling that we cannot eliminate, okay, let us control birth of a SS newborn. Now the other thing is, these are modules available which have been prepared by us from tribal, and there has been modules for patients, awareness, general public. Okay, they should come to us. The modules and the audio and the videos are such that they should come to us and should be massive. Here I just want to tell you, they are in very simple language. You can see niche, awareness kaise hai, blood and blood, very simple things it is there. The other thing, there is a module on awareness, there is a module on management. The management has to be uniform. And there are PPTs for management and write-up also, what one should speak on, it should be uniform. So I think one has to be aware that we have these. Other thing is, Madam, Shikha Madam, we have a module for teachers. awareness. As you rightly said, it is very important. Most of the time the child goes to the school and they just remain absent because they don't allow to drink water, they don't allow them to go to washroom, go with a bag. So I think teachers are very important in school, parents and doctors, mind you. Even doctors' training is very important, because when I do prenatal diagnosis and then Dr. Chandak sends a report of SS and they go to our obstetrician, नहीं कुछ नहीं करने का है तुमको, नहीं. I think वो बहुत important. मेरे 10 में से 2 ऐसे निकलते हैं. I think that is not right. We need to have something for doctors also. Now these are through, I'm not going to show, but in 16 tribal languages we have audios and videos. Yes, we all must be in. We also know the plan. I'm not going into this, but center of competence. I think this is another thing which are required, which are going to be 17 aims in India. Yes, as of now, which can, because there are many patients who require AVN or hip replacement. What are we doing with it? There are list of patients. So I think we can refer them to such facilities, bone marrow transplant and prenatal diagnosis. I think what is unique is no country in the world has such mission project with so much of budget. Whatever people may say, no globally has such a program. And I think this portal launch, data management, I think there is a manual for mobile application which is there, right? And if you look at it, they are using the portal and you can see. But only thing I am worried about is the follow. We are screening and I don't know what about the follow. Yes, I think we need to develop system and somebody should see that. Now one thing I would like to tell is, in Maharashtra, even in Madhya Pradesh, there are 2 very good studies going on. A newborn screening and follow-up for at 10 centers. So I think Jabalpur is one of the center from Madhya Pradesh. Jodhpur also, yes. Jodhpur is there, Nagpur is one, Chandrapur. So I think this study is another study which will tell us when you follow up from newborn till 10 years, you will know what is the real presentation phenotype, what is the severity, many questions. Because I say infection is very common. For me, anemia, infection and pain, these are the main things. People say, no, infection ka, we give penicillin. In spite of penicillin, my newborn, even Jabalpur, I see they are repeatedly admitted for infection. You give everything, vaccine, everything, but they are admitted for infection. I think this study would be remembered. And the other is a hydroxyurea study. I'm not going to discuss here. The other is CRISPR initiated by CSIR. And I think they are progressing very well. But one thing I would like to tell, especially when there are warriors, see, we cannot have gene therapy immediately. Many of them come to me, especially college students. Madam, gene therapy आ गई है. FDA approval हो गया 8 December को. Please, it's not practical. Huh? And it's you live a near normal life with whatever treatment we have. So don't एकदम think of कि हमारा gene therapy हो जाएगा. There are many buts and ifs. It's not easy, not without complications. So everything has something. But future is very bright for you. That's what I want to tell. Yoga, traditional medicines, Ayush is coming up in a big way. Many studies are going on. About Maharashtra, these are the districts which have been done. Now my concern is 8,000 SS patients have been diagnosed. What about that? I don't know. So there are many unspoken challenges and invisible struggles still with everything. And one thing I will like to tell is very important. We always insist, अरे vaccine नहीं है मेरे पास pneumococcal, penicillin नहीं है, hydroxyurea नहीं है. Supportive management is equally important. Giving hydroxyurea without support, पानी नहीं पीते, infection में जाते, बहुत nutrition अच्छा होना चाहिए. I think we do not stress on that. Even me, I think now I've realized it is very important that supportive is as important as medicine. हम सिर्फ hydroxyurea वगैरह की बातें करते रहते हैं. I think I'm going to stop here. Otherwise, I'll keep on talking. So yes, thank you. Thank you.
Great perspective on sickle cell disease program in Maharashtra. Next, we look forward to presence and our privilege to invite Dr. Neeraj Chandler sir. Sir is the Chief Scientist and Director CSIR Sickle Cell Mission. Sir will कोई नहीं आप बोल दो. Sir will brief us on
So I would send in a formal request. So I just take this opportunity to personally inform.
You consider it done.
Okay, thank you.
Hello. Hello. Okay. So thank you, Ruchita, and thanks, Mr. Gautam and Lalit, and thanks to all the dignitaries. I've met Dr. Ruby. Last time couldn't meet you and Babu, so it's a good privilege for me. So first of all, I must apologize for holding this inauguration session. Yesterday, we decided to go and get the blessings of Mahakal before we get into this Maha thing, never realizing that the Mahakal may show its fury by this fog and rains and all that. So anyway, I think that it's a simple statement that it's not still a very smooth road. It's a bit bumpy. But then I always think that we have lots of opportunities. We probably know most of the things. And at least for one, I don't want to look at the past, But that's equally important because that really tells us that, where did we actually fail. So please consider this as my honest statements and not a criticism or anything. Since everybody is talking about I, so I thought I'd just put our work that we have done in the last few years or so. So 6-7 years back, when we started looking at one of the diseases that CSIR wanted to make a difference, in the background of some of the work that me and my team had done 20-30 years back on this phenotypic heterogeneity and mild phenotype. So ours was the first group which showed that why is it so, and there is a different genetic basis. By the way, I am a medical geneticist, so some of the genetics will come into my talk, which till now hasn't come up over here. So, and at that time we just started, I made a team of people, and then we started looking for people around. And actually, I was pleasantly surprised. They were all around pockets of excellence. And what we have been able to do is only to bring these pockets of excellence together, taking their information, and that's what I'm going to tell you in next 5 minutes. So, like Dr. Deepti, Dr. Patra, and before that I must say that, a man is known by the company that it keeps. So, before I started on this, I thought I will have keeping a good gender balance, Dr. Patra on my left side and Dr. Deepti on my right side, and then went on to explore throughout the country. And I'm really proud to say that starting with Chhattisgarh and then to Maharashtra, now we have gone on to work in some parts of Madhya Pradesh, Rajasthan. We are going to extend into some places of Jharkhand and Odisha also. It's very easy to take these names as states, but it's not that. These are just niduses that we have been able to put. And it probably is a conglomeration of, what is largely known, but with a little bit of innovation. So what is it that, we have been able to do? You have heard from Dr. Patra, Dr. Deepti. Just to put a very brief summary, that we developed a comprehensive approach, put it in practical application right from population-based screening to school children screening to adult screening to adolescents to newborn, then to antenatal screening. And from this comprehensive experience along with Dr. Patra and many others, it's something like close to 28-30 lakhs of people who have been screened. So imagine, as he was saying, there's a huge burden of patients. We have only 2,500, 3,000 just now, and for them also we don't have full clinical details. Something that everybody wants to know before saying that, oh, what is it that is so different? What can we do? How can I tell a person that you are different, you are not likely to develop the disease? That was one thing that we started doing. Second was that there is a problem of a test, although Dr. Patra very passionately talked about solubility test, but I for one will completely differ from him. I am happy that he is not there. solubility test is not the way, and it's unfortunate that we find still in the National Sickle Cell Anemia Mission that solubility test is the first test and second is electrophoresis. Both of them have at least 10 to 15% of false positivity or negativity, and that became one of the motivation for us, because the screening test, which is the card test that requires at least 250 rupees per person a few months or a year back or so, along with that the HPLC, which requires again an infrastructure. So we started to develop a particular test which can be very, very easy and acceptable. Not to go into much details. Second point is that everybody talks about prenatal diagnosis, genetic counseling, but suffice it to say that you cannot go for prenatal diagnosis unless you have a molecular confirmation of the disease, and this is the basic principles of genetics as far as I understand, which means that even if you identify a carrier, even if you identify a patient for any hydroxyurea treatment or for any prenatal diagnosis, you need this genetic diagnosis. It doesn't figure anywhere, nowhere in National Sickle Cell Anemia Mission. So 2-3 years back we had anticipated this and we developed a test which just requires 0.25 microliter of blood, which is 1/100th of a drop of blood which you can take on a spot. And from that spot one can take a small punch and directly set up a PCR and that product can be detected. This is a technology which we have patented, and currently our whole effort is actually to make it available to anybody and everybody. Clearly I or my team cannot do this, so we are really looking for partners who can actually take this technology. We are happy to train people in this. We are happy to post our people over there. We have made a groundwork of the infrastructure which will be required. So through this particular forum, I am really proposing that anybody who wants to develop this, particularly with the corona background, I think everybody knows what is RT-PCR, what is DNA, what is RNA. So it's no more a big deal. So we have already done it at many places, including Rajasthan and some places in Madhya Pradesh. I have also discussed some time back with Dr. Ruby also, and hopefully we'll get some positive response. Now, just 2 or 3 more minutes, that the problem has always been that the focus has remained on tribal people. Through one of the studies that Dr. Patra had published in 2015, when I think there were some 10 lakh patients, 10 lakh subjects or so, showed that there are 10% of sickle cell, 10% of scheduled caste and scheduled tribe, but it is 6% in the common general population also. And the clear hypothesis is that when there was malaria rampant, at that time sickle cell gene got selected. But then subsequently it has now gone on and spread so that the allele frequency is so high that even in the general population, even by random mating, this is going to go. Which means that the screening has to encompass everybody, and that's where National Sickle Cell Anemia Mission has really talked about a wonderful thing: screen everybody, put a priority on the age and the marital status. I just have 2 more points to say, that something which Dr. Babu already mentioned about, that we are talking about 7 crore people. I don't know what period. I hear that they have to be screened in 3 years, 4 years or whatever. I think that this is really a Herculean task, and going by the messages that I hear from everybody or from elsewhere in any of the meetings, everybody talks about their failures, their best attempts, and yet not being able to reach a target. For one time, just recently we had a monitoring committee meeting, so I had requested one of my colleagues to look at how many patients subjects have been screened in the portal, which is there in the portal. And what we found that 85 lakh people have been screened, and clearly that will come to maybe about 1% or so. So we already have these many patients. On 10th of May, when we had looked at, there were about 21 lakh subjects who had been screened. So in about this 7 months of time, it's only 64 lakh only which has been screened. If we go by this date, madam, say something like 2.5 lakhs per week, I don't think we are going to be able to achieve this. And that is where I am proposing, in consultation with many people. We have fought with our colleagues, including Dr. Jain, Dr. Patra, and many others also. But this is something which we think probably can be a solution, and I really invite any kind of discussion. Currently, the government says that do any test you think possible, but within ₹100, right? It wants everybody to be tested, but the cost has to be less than 100. And as far as my awareness or knowledge goes, no test is less than 200, 250. You can do arm twisting, that can go for some time. You may be able to reach 100, 150. I'm not sure whether it will go on for long term or not. Secondly, there is a supply issue, because these are all test kits which are all developed abroad. You never know what is 250 today. When the market increases, they might make it to 500, or they may again start you arm twisting or so. So the test that I was talking about, the whole blood PCR, we have this less than 100 rupees. I'm happy to announce that we have tested this on more than 10,000 subjects. There is a 99.6% sensitivity and 100% specificity on this test. This test is currently being developed into a kit base in association with a company. So I hope that in next 2 to 3 months time this should be possible. Number one. Second thing is that I personally feel, again this is where I'm talking about myself, because nobody agrees to my opinion on this. But I think that if we talk about any of these screening tests, the card test, at the best that takes about 10 to 15 minutes for one test. Which means if we talk about practical logistic way, that if I am doing the test one person, then I can do probably 4 or maximum 5 per hour. And 8 hours a day, if I count, then 40 tests per person, and these all require data entry, printing a card and other things, and which essentially indicates that you need so much manpower and all these things. Second is that you give the report and that's it. Your contact with the patient is lost. We assume that if we are giving the report immediately, we will have a better acceptability. But no, it will only have better acceptability if you are able to provide some immediate solution to the person, which is not so. So to me it seems that it's better that the reports are withheld. They are distributed the next day or in a camp way, so that everybody is counseled in a way, patients are identified, registered, and then the treatments are given. And I'm not so much knowledgeable, but I was very happy to see what Dr. Botha presented, as such a beautiful structure actually exists. One more point which I would like to mention, that what would be the solution for this? In my opinion, the blood collection and the test should be split. These can be 2 different activities, because the moment you are doing these kind of screening tests, you need somebody with a unique expertise. The person has to know where to put the drop, how much time to keep, and all that, and then has to also read. Sometimes the reading may also be difficult. 95% it will work. I think that if we think of having even 8th class or 10th class people just to have a finger prick and put a blood drop on the dried blood spot as a dried blood spot, that can be stored for years together at room temperature. It can be transported anywhere, and also it provides one an opportunity that you have the blood in store with you, so that if you want to do anything in future, and I'm sure genetics and proteomics and other things are the future. So this is a strong opportunity. We have tested this at least 4 or 5 places by taking newborn screening cards, which were just collected randomly, without any precaution or anything. And we have found more than 99.8% concordance with HPLC results. We have also collected the cards. We have also requested at Rajasthan in particular to go and collect blood sample and then draw a spot over there and then send those spots over here. There is no contamination. There is near 100% concordance between HPLC and these results. Based on these results, to me it seems that even if you think of using the sickle cell card or something, it may still be a strategy which can be debated, discussed, because I'm not on the field, whether one can split this blood collection part and then transport and others. Last point from my side, that we have now developed a model where this infrastructure of a limited infrastructure can be developed, which contains a small PCR machine, pipette man and others, within a cost of 15 to 25 lakhs. It can be set up at a place, and my vision is that the blood is collected at periphery in a spoke and wheel model. There are 10 centers, 10 collection centers which may be linked to this district or primary health center. People can be trained, and those samples can come with a puncher, an automated puncher. This test can be done. Proof of the pudding is in eating. I just end by saying that if properly collected samples, close to 300 samples can be done in 3 shifts in a day's time, which I think that by no method 300 samples can be screened in a day's time. And this I am talking only about 2 people with this kind of infrastructure. So friends, I have tried to propose a solution which is based on experience with lots of people, both on field, off field, our own experience. And this is what we are trying to implement. We are trying to do it in Rajasthan, in Chhattisgarh, in Jharkhand, and hopefully if Madam agrees, then in Maharashtra also. Thank you very much for your patient hearing, and I request you all to please be critical, because it's good to get criticized in front of, I hope you all are friends, than to fail on the field. Thank you very much.
Thanks, sir. We very appreciate your enlightening guest. Miss Priyanka Das ma'am. Ma'am is NIAS Mission Director, NHN, Madhya Pradesh. Ma'am will enlighten us on the keynote address on roadmap of sickle cell disease care in Madhya Pradesh. That even sickle cell program has started it. It definitely shows the way, and when we talk about stigma, you all prove that there is no stigma. So I would congratulate that. Now coming on to the specifics of Madhya Pradesh. And like Dr. Chandak said, I'll be a little critical of the entire way this was, is being conducted, because some of the speakers I found was not in sync with what is happening in the state. So first of all, I would like to say at what stage we are. There are certain things on which now there's no point of return. So first of all, Madhya Pradesh is poised to do the testing. We have excellent testing infrastructure. We have HPLC across all our districts. We have aims to support us with high-end tests. Plus, Madhya Pradesh is one of the leading states which is open to new technology. So we have tendered. We are doing our testing on the field using the point of care techniques also. Now, first, addressing the testing part, because till we test, we don't know what we are going to deal with. So see, the entire, what I feel is the entire testing environment is on an uphill curve. The market will evolve, the technology will evolve, and the market dynamics and research will determine the price. So in Madhya Pradesh, we are always going in for short-term tenders so that we have scope for including the newer products which are there on the market, which meet our requirement and standards, and also it gives an opportunity for fair competition. So that I want to clarify at the very outset. Secondly, yes, we want to screen. We want to screen quickly, but we are not in as much hurry as you are trying to project. Why? Because I do not want to compromise quality over numbers. The moment this message goes to the field कि आपको 300, 300, 400, 400 प्रतिदिन करना है, पता नहीं टेस्ट भी करेंगे कि नहीं और कुछ भी रिपोर्ट आ जाएगा. That will waste and foil the entire effort. Yes, I understand efficiency. We will support efficient methods, but we will want original, actual, factual testing. Secondly, only testing does not help at all. For example, in Madhya Pradesh, we have tested more than 20 lakh people, and like ma'am said, in a very short period of time. And we have, identified 10,000 diseased patients. So,
what do we do with those 10,000? We actually need to follow up and have line list and do something about those 10,000 people proactively. Then I have another number of for 30-40,000 people who are carriers. They require different kind of counseling. So the impact of testing is we need to gear up the mechanism for the remaining two parts. So what we did in Madhya Pradesh is we do have a treatment booklet. Madhya Pradesh, we designed it because we know that we want the patients to come in for regular follow-ups. But that is at a very, very nascent stage. And like, after hearing you all, we also need to document, and here I would like to request Deepti ma'am and all the other, eminent qualified people to chip in, and we need to have a profile of the clinical, invite the civil society organizations to chip in the counseling part. The training orientation part has to be done by our medical professionals, by the higher and expert medical professionals, because they need to be updated continuously. And lastly, we also need to look at centers of excellence as well as primary level centers which can cater to the additional load. What in Madhya Pradesh we did, because we always have a annual exercise of preparing the plan. So we have already included in our NHM PIP, we would have dedicated sickle cell wards, because the ward that you are currently working in, I can foresee कि वो आपका 6 बेड से चलेगा नहीं. So we have already asked for those 20 districts that we want to scale it up to 20. But वो 20 भी sufficient नहीं होगा. जब तक हम 20 करेंगे तब तक आपको 40 की डिमांड हो जाएगी. So we need to strengthen our concerned PHCs and CHCs. So वो plan भी करना है. And how should that sickle cell ward operate? Let us decide that. मतलब हमें आगे इस पूरे कॉन्फ्रेंस से मेरे लिए टेक अवेज क्या है? आप सबके लिए इंडिविजुअल प्रोफेशनल टेक अवेज होगा, बट फॉर मी एज अ स्टेट द टेक अवेज वुड बी हाउ डू आई डिजाइन माय ट्रीटमेंट प्रोटोकॉल फॉर चिल्ड्रन लाइक न्यूबॉर्न. यू सेड इट इज ब्लैंक राइट नाउ. वी हैव कॉमन SOP फॉर प्रैक्टिशनर्स. सो लेट अस हैव इट cohort wise, age wise, for newborn, for pregnant, for तो वैसे करके हम बनाए. जैसे हमने ट्रेनिंग मॉड्यूल्स तो बना दिए, लेकिन पेशेंट के कोहॉर्ट एनालिसिस करके उनके जो स्पेसिफिक रिक्वायरमेंट्स है उसको एड्रेस करें. सेकेंडली, हाउ we went on a visit in Gujarat. We saw a full sickle cell hospital. We might not be in a condition to replicate that hospital, but at least in every district that we are firstly catering to, there we should have the wards, and those wards में clinical management कैसे होना चाहिए, क्या facilities होना चाहिए, क्या facilities की layering होनी चाहिए. अगर वो input अभी मिल जाता, because we will start executing. मुझे फिर 6 महीने बाद आप कुछ नया चीज बोलोगे तो मेरे लिए readjustment and tailoring में problem होता है. So all great minds are here today. So please give us the inputs on that. Lastly, I would also like to say that we need to have an informal group. We cannot have conferences all the time. So all the like-minded individuals, professionals who are working in the field of sickle, at least in those 17 states. And last but not the least, I still think, and I think this is the biggest criticism of the program, I don't know why this is taught as, somebody told me it's taught as part of tribal medicine. I totally agree with you all that it is not a tribal disease. At least what we are even encountering in Viksit Bharat, we are finding this disease amongst other populations also, non-tribal blocks also. So this program definitely has to expand. So even from the GOI level, maybe this thing will go in for a course correction or some sort of revision. But yes, maybe the prevalence or incidence may be more. So we need to take up those areas first. So we are taking up those areas first. But if I talk about Madhya Pradesh, I have 52 plus districts, I think 53 or 55, I'm not very sure with the count right now, but 20 are tribal. But so the majority of the chunk are not catering to right now. So वो भी आगे जाके एक challenge होगा. 3 साल बाद फिर एक lopsided सा चीज होगा कि, and why are we thinking in the age of globalization and industrialization and urbanization that the tribals will be restricted to the jungles and pockets of their hamlets only? They are coming out to study, they are coming to the metropolitan areas, they are taking up jobs, they are working in offices. How can we restrict screening only to the tribal districts? It has to happen across, it has to happen everywhere. So I think this is a message and takeaway for all of us here. And I thank you all very, very much for coming to Madhya Pradesh and spending your time. It shows the seriousness and commitment, not just of the state, but of all you people as individuals and professionals who've taken out the time. Thank you.
Thank you.
Thank you, ma'am, for your valuable information. I would like to invite Dr. Sajin Bansal sir. To felicitate Dr. Nishant Saxena. I would like to invite Nishant sir to felicitate Dr. Sandeep.
सर एक मिनट आइस क्लोज हो रही है सर आपकी.
I would like to invite Dr. Ruby Khan ma'am to felicitate Ms. Salunaz. Rashika Malik ma'am. I would like to invite Dr. Deepa Bhatt ma'am to felicitate. I would like to invite Dr. Dipti Jain ma'am.
Asthenia and maybe later on if the hysterectomy is being planned for them. So, and because of the complement system, actually protect them from the encapsulated organism because of the functional asplenia or hyposplenia. These group of patients are they actually are prone for infections to the encapsulated organisms. And most important among these is the pneumonias. Streptococcus pneumoniae is one of the major culprits, along with the Neisseria meningitis and the Haemophilus influenzae type B is the major infection which is important in these group of patients. What important vaccines, special vaccines which are recommended would be a pneumococcal vaccine, a meningococcal vaccine, HIP if they are not vaccinated before, annual influenza vaccine, and a typhoid, yes, encapsulated because again salmonella is an encapsulated organism, a typhoid vaccine. So it is very good that we have most of the vaccines which are included in the universal immunization schedule. So pneumococcal vaccine is included, the 2 doses and along with a booster. So if these group of patients who actually they do not get these vaccines, pneumococcal, or who miss the vaccination, then they are advised 2 doses of the polysaccharide vaccine. And if these group of patients who are actually not at all immunized, then they should receive 1 or 2 doses depending on the situation of the conjugate vaccine, followed by a polysaccharide vaccine, and then a repeat a vaccine is also to be given after 5 years of the last vaccine. So usually 2 doses is sufficient. Then talking about the meningococcal vaccine, so definitely these are not included in the universal schedule. So these are actually kept for only the high risk group patients. So we are recommending it as single or the 2 doses. So what IAP, Indian Academy of Pediatrics, they recommend 2 vaccines of meningococcal for 8 weeks apart, starting from 2 years to 55 years of age group. But some of the agencies, they do recommend only 1 vaccine is suffice for meningococcal. Then talking about the typhoid vaccine, so again it's not included in the universal immunization program of India. So it is again strongly recommended at least 1, the conjugate vaccine. So 1 dose is sufficient for typhoid, started from 9 months onwards, so we can give them. And influenza annual, because looking at the risk of pneumonias and upper respiratory infections, so annual influenza vaccine is recommended. HIB, I would tell that HIB vaccine is a part of the pentavalent vaccine which is being given to them, and we do not have a separate vaccine. So it comes in combination. So what we are practicing commonly is we are giving them a pentavalent vaccine along with in the universal immunization program, 6, 10 and 12, 6, 10, 14
patient. So we will take more cross questions later on. We'll finish with the pre-fixed questions now. Over to Dr. Monica. What is your guidance on the pneumococcal vaccination schedule? Because we say that that's the most important one, both for infant as well as catch-up for adolescents.
who have missed this vaccination.
If the patient comes at the age before 24 months, so conjugate vaccine is a must because that is providing herd immunity as well as basal calories are avoided with that, prevented with that. So ma'am, after giving PCV, if the patient comes later on after 2 years of age or so we can prime it with 1 or 2 doses according to the age group the patient is coming in, followed by polysaccharide vaccine 23 or 10 whatever is available, and followed by booster at 5 years of age.
Yeah, I would like to ask here, is it supplied in the government medical colleges? The basic concern for us is in the government hospital only PCV 10 is supplied, not even 13 and 23. So how shall we ensure that in future this comes into practice?
Since the ICMR-National Yojana has come, and if the patients are under those registered, so we can call from that Yojana, from that scheme.
Listening from many speakers now that it's difficult to move them from different geographical difficult locations to the tertiary care hospital. So will it be possible to bring the same to the primary healthcare system?
Ma'am, that I'm not very sure, but the thing is that if the patient is admitted, then they get all the benefits of ICMR-National. Once they are admitted, they will definitely get.
So I think that problem should not arise now. It was few years ago, but last 2 years, Government of India is paying for Prevnar for all newborn who have sickle cell disease. You should ask for it if they are not giving.
Ma'am, we don't have it.
You don't have, you ask for it. That they are supposed to get, and it is under sickle cell program, control program, and you should get it. Special, ये करते थे हम लोग. Indent, yeah, special indent under sickle cell. Meningococcal also.
Indents earlier, ma'am, but now since the recent MS has come, he always says, ma'am, we don't have budget, so we can't provide. So this is the answer we're getting every time. Otherwise, earlier we used to have, definitely we used to get.
No, I think you should get, and now more patients are going to come with the mission project, and I think in the mission project, vaccination is a very important component. You should get. But if you do not get, what I want to tell you is, try for that. In the meantime, don't leave the children like that. Put them on penicillin. Even if you are going to give them vaccine, you are going to put them on penicillin because we don't know what are these serotypes which are covered in that vaccine. And probably now Prevnar will be replaced by 10 coming from Serum Institute India. So at the national level, we are going to have some revisions in pneumococcal vaccine. It has yet to come, but it will be there.
But the medicine is also not available freely, ma'am.
No, it is, we all our children get. See, there are 500 newborn. 500 newborns all over India.
Supply is not there, ma'am.
Yes.
Hospital supply is not there. We can ask them to buy, but they don't even have money for buying.
It is very cheap. I think your hospital should buy, like, there is a GR which says sickle cell have all free investigations except MRI and all free medicine except bone marrow treatment नहीं है. सब उनको फ्री मिलना चाहिए. वो GR देखो 7 दिन बाद आएगा. वैक्सीन ऐसा तो नहीं है आज ही देना है, लाइक एंटीबायोटिक इन्फेक्शन के लिए देना है. यू कैन वेट फॉर सम टाइम. वो पेशेंट क्या करते हैं, आज नहीं है तो दे विल नेवर कम फॉर द वैक्सीन. सो यू हैव टू मेक श्योर, टेल देम आज नहीं है, तुम्हारे घर में भी चाय शक्कर खत्म होती है, कभी बाद में आती है, वैसे हमारे पास भी आ जाएगा.
Also the list is given now, pneumococcal to typhoid to give. So is it that everything, because not everything is covered,
yes.
So how
ideally they should all get, they should get all these vaccines, and especially what I will add to what Shweta said is splenectomy. If the patient is going to be splenectomized, still we have many hypersplenism patients, so we do give meningococcal and pneumococcal at least 6 weeks before, always, and give penicillin also lifelong in those patients.
Thank you, ma'am.
Meningococcal vaccine is available, ma'am.
What?
Meningococcal vaccines?
Yes, there are 3 different types.
How will NASCO assist in bringing these all kind of vaccination, so which is available for all the patients who are, so how can patient organization help in government getting these things, because it's, I always believe working for rare diseases that it's the warriors who can really make a difference while seeking their rights?
मैं पहले तो मैं ये बताना चाहूँगा जैसे बहुत से स्टेट में विधायिका अवेलेबल नहीं है ये जो वैक्सीन है, बट मैं राजस्थान में हूँ और राजस्थान में सेंटर ऑफ एक्सीलेंस का नर्सिंग इंचार्ज भी हूँ साथ में। तो मेरे वहाँ पे PC13, PPSP23, न्यूमोकोकल मेनिंगोकोकल और एंटी फ्लू हम सभी बच्चों को दे रहे हैं जितने हैं। तो हम ये कोशिश करेंगे इसके लिए कि जिस तरह से राजस्थान में अगर ये फ्री ऑफ कॉस्ट मिल रहा है और सभी पेशेंट्स को मिल रहा है सिकल के, तो कंट्री में इस तरह की कुछ गाइडलाइन होनी चाहिए या जिस तरह से अभी जो गाइडलाइन आई है उसमें स्पेशली वैक्सीनेशन के लिए भी कुछ ऐड होना चाहिए ताकि ये सब चीजें मिल सके।
एक मिनट मैं बताऊंगी, मैं गई थी जब उसके पास जस्ट एकदम कम टाइम में उन्होंने पूरे वैक्सीनेट।
मैं आशा करती हूँ कि आप
पेन तो होता ही है, मैं पर जो इन्फेक्शन से जो डेथ्स होती है हमें कुछ प्रकार तक रोक सकें, तो हम लोगों ने इसको मॉनिटरिंग अच्छे से कर रखा है और हम लोग इसी तरह से अभी भी हमारा जो राजस्थान गवर्नमेंट है उसने हमें अभी करीबन 1500 डोज के लिए अभी एडवांस में हमें पे कर दिया है कि आप खरीदिए, और जो पेशेंट डायग्नोस होता है उसे पहले से PC13 के लिए तो हो गया है कि वो उनका डोज आ चुका है अभी, क्योंकि हमारी स्क्रीनिंग काफी लेट स्टार्ट हुई है और अभी तक हमारे पास ज्यादा नंबर्स तो नहीं है, पर 1000 के आसपास हमारे पास अभी पेशेंट हो गए पिछले 6 से 8 महीनों में। तो उन सभी को हम लोग वैक्सीनेशन और जिस तरह से मैंने बताया था सिकल सेल डे पे हम लोगों ने स्पेशली इस चीज को ऑब्जर्व किया था, जिस तरह सिकल सेल डे मनाया उसके साथ ही वैक्सीनेशन का भी एक प्रोग्राम रखा था ताकि इससे अवेयरनेस
immunization coverage of ICMR, so the sickle cell patient across India.
First of all, I would like to thank the organizer. Our center particularly works on tribal diseases, and we have always identified the health issues that pertain to communities in Madhya Pradesh or in other parts of India, and try to draw the attention of the government there. And as such, in the immunization program, and as Nishan Saxena and their groups have a good social science background and they are experts in community mobilization and awareness creation. So our role would be to do that for the nation, and also I'm not a clinician. I have a researcher perspective on that also. The thing is, we take up pneumococcal or meningococcal vaccines, which are basically useful in Indian scenario, but most of the studies are based on the African cohorts. We are different as compared to the African cohorts. So there could be other organisms which are more kind of virulent or pathogenic. So we need to have a clinical profile of Indian patients and the infective organisms, so that, like ma'am said, if despite vaccination they could be infected. So those infecting organisms we need to identify and have a profile of the infecting organisms, so that we are able to give the tailor-made antibiotics or the vaccines. Maybe pneumococcal may not be essential in India. So we have to kind of identify our infecting organisms and have a clinical profile rather than following international guidelines. Thank you.
We are really facing, like as pointed out by Dr. Monica ma'am, that we are not able to get the vaccines, or the secondly we have to then टेक दी हेल्प ऑफ सम NGOs, और कितनी बार मुझे बहुत बार काउंसिल करना पड़ता है, उसके बाद बहुत आफ्टर मल्टीपल काउंसलिंग पेशेंट्स गेट सम वैक्सीन्स, पर वो भी पूरा वैक्सीनेट नहीं हो पाता है. सो अवेलेबिलिटी इज रियली इशू, एंड देन सो आई थिंक NHM वी शुड, आई मीन एज मैडम सेड कि हमें भी थोड़ा सा आप देखेंगे कि एज शी सेड सिकल सेल को फ्री है, सो वी विल फाइंड द वे आउट. सेकेंडली
डॉक्टर रूबी बिफोर दिस मिशन प्रोजेक्ट, and we used to divide it into medicine, vaccine, avian surgery, cholecystectomy. हम ही डिसाइड करते थे डिपेंडिंग ऑन द लोड. सब मेडिकल कॉलेजेस में उतने पेशेंट्स नहीं होते हैं ना. So sickle सिक्कल के फंड्स अलग, उसका परचेस अलग, और हम ही करेंगे ना GRD का भी, वो हम नहीं करते मुझे लगता है, और पर्सनली करते, नया नया थोड़ा प्रॉब्लम होता है, बट वंस इट कम्स इनटू द स्ट्रीमलाइन होते रहता है.
Yeah, ma'am. Actually, Madhya Pradesh is doing the use of this vaccination, so that they are not
be trained, because once they'll understand the importance of vaccinating these children, so they are going to counsel the parents. So time consumption is it is very important that they themselves should be aware, and they should able to spend time on counseling of these group of parents. Particularly when I am talking about the sickle pediatric sickle patients. So many of them, when they come to me, they don't know about the importance of the vaccine. अच्छा मैडम ये भी कुछ होता है, ठीक है. So awareness is very very important, which is need to be populated.
Vision for immunizing sickle cell patients in the state, and what is your suggestion for other states too?
Turning to be the ultimate destination for conferences. So I welcome you all. As per your question, I want to say that I was vaccine and logistic officer at the Ministry of Health. The decision and guideline is taken up by Ministry of Health Immunization Division in the country. As far as immunization, procurement of vaccine is concerned, it is done with the ultimate advice of MTD. So the PC vaccination used in sickle discussion, and we are not getting any supplies till date. As Dr. Ruby said, health is a state health subject. The state can go beyond, procure the vaccine as per their requirement. We have 10,000 listed cases, and looking to the number of morbidity and mortality, pneumonia is one of the leading killer disease in the country as far as the 5 population is concerned. So the clinical trial has been done in 2,363 cases, though it's very limited. 34 adults, 168 toddlers, and most common adverse reaction was painful injection, 49%, fever 52%, irritability. That is, it is a very safe vaccine. And we have practiced in COVID vaccination also. When we have introduced the vaccine, there was a lot of dejection from community side. All the vaccine carriers were going and they were coming back to us saying that we have not received any injection as vaccine above 18 years. That too in tribal events. So we counseled them, and our counseling was, देखिए बीमारी तो लाइलाज है, बट वैक्सीन लाजवाब है. इस प्रकार से जैसा मैडम कह रही हैं कि इसका एडवोकेसी का बहुत फर्क हुआ कि एक बीमार जो हमारा वैक्सीन प्रिवेंटिव डिजीज ऑल आर मोस्टली non-treatable, but vaccine we have seen demonstrated it's a guarantee of safety, because we have eradicated smallpox in 78, we have eradicated polio in 2014, and we have eliminated mother neuter tetanus. So we have got that evidence base that vaccines are safe and effective, and we are going for the tender of the vaccine, and we will be the leading in the country as far as PCV introduction in SCD.
Definitely, ma'am. Yes, it's a big yes. And therefore, ma'am, that answer to this and fruitful also. And ma'am, if you talk about penicillin prophylaxis, if the patient has to take for a longer time, then they will definitely drop in between. But vaccine, once vaccinated, then another second or third, as per the recommendations, they can definitely come. So vaccines are safer and very easy to follow.
ये बहुत जरूरी है. स्वाइन फ्लू वैक्सीन करके बोलो और 2 हर साल बहुत जरूरी है. हेपेटाइटिस बी ये वो तो नेशनल प्रोग्राम में आ गया, तो हेपेटाइटिस बी का तो वैक्सीनेशन हो जाता है. ठीक है.
It was the Prevnar which was supplied in the government setup, and it was directly Government of India was supplying. It is from July onwards that we are using the Serum Institute vaccine, and it is said to be 10.
That's what I'm telling you.
That is what I am saying. Now the Prevnar is coming with the 19 variant also, right? So they finally going to cover 23, because I had been in project with the John Hopkins, so I know about it. They are intending to come out within this year with the 19 variant, right? So we will keep on chasing, but it is the cost effectiveness for the general program that all children are covered, and probably Serum has, and strains which are prevalent in India.
Exactly,
right?
madam, you are
Only-
right.
Yeah.
And that is why we are going to recommend 10 is going to be recommended now.
And 24 is again after 5 years the pneumococcal incidence will be diagnosed. They have a basic protection up to in 6, 14 and 9 months, which is acting as booster. So they will not require essentially कि बिल्कुल उनको नहीं मिला तो some havoc is going to happen, and rather 23 valent pneumovax, the kill vaccine will suffice, which is much cheaper, that can be done. Second thing, meningococcal, yes, we do talk and splenectomy, autosplenectomy, or we have done the splenectomy, then it will be indicated. But otherwise, it is a disease mostly of the cold countries. So in West, they will strongly recommend normal population is also to be, but it is not that until unless, and we don't have data also regarding how much is the incidence. Rather, typhoid is the necessity in our scenario, because these, if they are poor and they will be eating and waterborne diseases are still prevalent. And my strong belief is that everything looking at the government, कि government supply करे, government ही free दे, what NGOs can also make the support group who are able to help them, like we see in thalassemia. They are getting transfusion in private nursing home, but for desferoxamine. And for transfusion in a nursing home, but for the free medication you are dependent on. So that attitude from the like, हमें क्या करना है, हमें क्या, but what the public has to do, that is also to be bring, like है ना, आप पोलियो सबको घर में पिलाने लगे, nobody wants to go to the booth. Why this? Why everything in your hand? So that has to be sitting here, that policy is to be recommended. That is my, and Ayushman, you can get the vaccine. It is, we are not having budget, reimbursed nahi hua, but we had been. And now the Ayushman is going up to 10 lakhs per family. Right? So it should not be. Right? Thank you.
To Bonda Babu sir. So how would the ICMR would like to address this implementation gaps in immunization for the patients with sickle cell disease? Subramanian sir.
Cohort in our institute where we look at the immunization schedules, and we are basically not a caregivers, so work done on. So, and we will continue that endeavor to find gaps in various disbursement or the procurement wherever it is found, and we will try to come out with a solution, and that our role is secondary to the caregiver, and ICMR will continue that endeavor throughout, and our main focus is identifying the
particular case-to-case basis rather than as a program. Okay, now program is focused on the screening. So the maybe next stage, it may cover all the components of care. Then we can think of that how to optimize the services in program mode. Definitely ICMR will work. Now ICMR has started working on implementation research on various public health problems in the country, right from primary health care to NCD care, many things, because if you go through the ICMR website, you will understand. We are not saying that we are not working on national programs. We are working. But programs should reach to some stage where we can say that these are the gaps. Then we can work on those.
Yeah, thank you, sir. It's like compromisable to adult health.
They never do splenectomy without a vaccine. The surgeon will never do. So I think all adults do not need. However, there was a demand from NASCO, Dr. Gautamji knows, Mr. Gautamji, that all adults should also get pneumococcal vaccine. But I don't think government of India is agreed to that for sickle patients. Those who need, yes, but not all.
COVID-19 was the only adult vaccine country had introduced, and second is
SCD will give us to others. BCG.
So we are going to take care.
I think Deepa, we forgot about COVID. Many patients called during COVID Can we take COVID vaccine, sickle? All of them were worried. And I think we all said that they should take. So I think that is one thing. Again, typhoid has new conjugate vaccine, है ना? तो which vaccine you have given, वैसे उसके booster doses देना ही है. वही मैं बोल रही हूँ, अपन pneumococcal को importance दे रहे हैं, मगर typhoid, influenza, ये vaccines important है.
Well, if Deepa allows, can I just add on to that? Typhoid, अगर किसी patient को 3 बार आ रहा है, तो उसकी खाने का और पीने के चीजों में आपको काउंसलिंग करना है, because that's hygiene.
Yes,
that
hygiene is also
yes, because vaccine is no compromise. That vaccine खा लो और गलत आदतें बरकरार
बच्चे इकोनॉमिक प्लेस, तो हमें ऐसा भी एज्यूम नहीं करना चाहिए कि एक रूरल ट्राइबल जगह जो कि शहर से बहुत दूर है, जहाँ पर लोग 1 या 2 एकड़ या 4 एकड़ की जमीन में खेती करते हैं, वो वैक्सीन खुद खरीद लेंगे. ऐसा हमें प्लीज एज्यूम. We would need we need different strategy for different economic groups, but then a lot of people need to be taken care by the state. So it is also very important.
Continue to argue, comment, as well as discuss for days together. So maybe let's all help each other in bringing a better delivery of this national sickle cell elimination mission across different states. So I thank all the esteemed panelists for your valuable contributions and suggestions. So anything more, let's maybe after this we can communicate for any of other doubts or any discussions we need to during the lunch or even later day. Thank you all. Thank you NASCO for giving this opportunity. And just to add few sentences, in Karnataka it is just in a beginning state. We are not even able to get hydroxyurea. None of the government is not at all supplying hydroxyurea. It's still in such a beginning state, and the phenotype as well as the presentations are totally different. So I request each of the states to help other states also, so that collectively it will be a better delivery of this particular program. Thank you one and all.
So we are going for the third panel discussion on comprehensive treatment for sickle cell disease patients to improve quality of life, including newer treatment options in future, which is moderated by Dr. Parikipalla Sridevi ma'am. And rest of our eminent panelists are Dr. Sachin Bansal sir, Dr. Jyotsna Srivastava ma'am, Dr. Bhavna Dhingra ma'am, Dr. Ravindra Kumar sir, Mr. Rahul Singh sir, Dr. Giriraj Chandak sir. Now I hand over mic to Dr. Sridevi ma'am.
Earlier in Madhya Pradesh in Indira Gandhi National Tribal University, Amarkantak, and I have been a part of National Task Force project of ICMR along with Bonta Babu sir and Deepa, and I was working on capacity building of the government healthcare system for sickle cell disease, and in that we have really achieved training of ASHAs for identifying the patients, and solubility tests for ANM, and we have established the primary healthcare system itself, a comprehensive care for the tribes in Anuppur district. So now I have been continuing the work on clinical manifestations, which Dr. Priyanka Das madam was emphasizing on. Now I am working on clinical manifestations in Anuppur district, and also continuing work in Vijayanagram district in Andhra Pradesh on stigma, economic loss, and pain assessment in sickle cell disease patients. With this brief introduction, I want to welcome all the eminent panelists of this session. Dr. Sachin Bansal sir, Associate Professor Hematology, AIMS Bhopal, and Dr. Jyotsna Srivastava, Professor in Pediatrics, Gandhi Medical College Bhopal. Dr. Bhavna Dhingra, Professor of Pediatrics, AIMS Bhopal. Welcome ma'am. Dr. Rahul Singh Parwaha, whom I know very well, Project Coordinator JSS, and Dr. Giriraj Chandak sir, Sir J.C. Bose Fellow, and he's also been advisor of NASCO. And I welcome you all. The panel discussion is on comprehensive treatment for sickle cell disease patients to improve quality of life, including newer treatment options in future. So my first question is to Dr. Sachin Bansal. Sir, we would like to know with your wide experience the role of hydroxyurea as medication for sickle cell disease, and even after treating hydroxyurea, patients are developing avascular necrosis. So what additional treatment do you suggest or can be done to reduce or prevent in patients who have not developed AVN yet?
Here decreases the clinical manifestations associated with the sickle cell disease, mainly via increasing the fetal hemoglobin and by decreasing the cytokines and by increasing the fluidity of the RBCs. So, how this hydroxyurea helps in the clinical manifestations? It increases the quality of life and the survival rate of the patient. Moreover, it decreases the transcranial Doppler velocity, which is being found associated with the increased incidence of the cerebral strokes. It decreases the occurrence or the incidence of the acute chest syndrome and the vaso-occlusive crisis. That's how, in brief, it affects the clinical manifestations and increases the quality of life associated with the sickle cell disease patient. Now, coming to the whether this avascular necrosis, which is being found in around 10% of the patients of the sickle cell disease, mainly in the male subgroup, rather than the female, males are being found to be more affected with the avascular necrosis due to sickle cell disease. So, avascular necrosis has more of the etiological factor rather than sickle cell disease alone. What are these other factors? These are the decreased bone mineral densities or male preponderance, increased incidence of the vaso-occlusive crisis, increased incidence of the acute chest syndrome, history of smoking, increased lipid concentration in the blood, alcohol consumption. So, saying directly whether hydroxyurea will decrease the incidence or this affecting the bone health of sickle cell disease patient, it will not, but indirectly by decreasing the incidence of the acute chest syndrome or the vaso-occlusive crisis, it does help in decreasing the acute vascular necrosis, which is being found associated in patients of the sickle cell disease. Apart from this, other modifications which can be followed for decreasing the incidence of the acute vascular necrosis are the bone mineral density can be taken care of by giving the calcium supplements to the patient along with the vitamin D3. Along with that, the counseling part is very important. As we have discussed in the last 2.5 hours, the psychosocial support. Why this is important? Because we mostly found the patients who are having a chronic disease, they have a more incidence of substance abuse, that is alcohol, tobacco, smoking, etc. So, the better mental health the patient is having, the decreased chances the patient will be exposed to the substance abuse habits. So this can be taken care of by the proper counseling and by decreasing the indulgence of this subgroup of patient into this substance abuse practices.
Caregivers or parents of children suffering from sickle cell disease regarding lifestyle and nutrition who had been admitted to admitted the child in crisis and getting them discharged.
And preventive therapy, its vaccine and everything we have talked about enough. But I would like to say that at the time of discharge, the parents are really very receptive about any advice which we are going to give it to them. And it's not only we have to talk to continue the drugs and the preventive therapy and the vaccination, we have to talk definitely. In discharge, you will find that we do right, prevent them from cold and less oxygen, but you have to counsel them. Especially about 3 things, they have to maintain the hydration in any form. Give them the number of bottles. 4 बोतल पानी बच्चे को रोज पीना है. Make 4 bottles. I think that will be feasible for everyone of any economic strata. I am sure about it, right? So for everything we are not going to get like they can't do it. So इतना उनको पानी पिलाना है, गर्मी हो, ठंडी हो, बारिश हो. Don't make them बारिश में कम की. Don't complicate the advice. Number 2, you have to tell them avoid too much exposure to cold, because I have seen children, they are not covering, they are not wearing socks, they are not using gloves, and then they really, this cold triggers the sickling and then they come again with this problem. Again we say don't hypoxia you have to avoid, but how? They will not say we are going to the Himalaya or high altitude, but the dental care and the general hygiene is to be recommended about all the patients, because that is another thing. You have to convince the parents that they can go to school in a normal way and they can have normal sports, running, studies, everything. Right? It's not like hemophilic children that they have to avoid injuries or they have to take care of so many other things. The second thing which I want to emphasize here about nutrition, first of all, that child needs a good nutritious diet, and it is nothing, this disease has no relation, which or the sickling episodes or crisis have no relation with any food. So child or the adult should have unrestricted, normal, healthy diet about it. I would like to counsel again, and we expect that they need really psychological and social support. The family should be there, their relatives should make a group, because some may be really suffering, and because we are getting married at present in the same social group, in the sense the relatives are same, some may be trait, some may be the disease, because we are still getting married in the same when they have a good survival, they should make a role model and they should provide the support, because really coming hospital again and again, they lose their wages, they lose their job. So it's a big thing, and for that matter, the treating doctor should talk to them other than the child once a while, what is the problem with their parents as well as the inside the family. And that is how we can provide them a really good outcome of the patient. Because many times they may be in depression, then they may ignore कि ठीक है यार इसको तो हर समय ऐसा होता रहता है, ठीक है थोड़ी बहुत problem तो they will ignore as such. So we need to look into the psyche of the parents and the family dynamics also. Thank you.
Very true, ma'am. Very true. Well said. Of newborn screening for sickle cell disease patients.
For newborn screening, and there's nothing much left for me to say here, but still re-emphasizing what she said, that the road ahead, if we want to plan for sickle cell, the road cannot be without newborn screening. Because we have been talking of comprehensive management of patients who already have sickle cell disease, but as medical healthcare professionals, our primary onus and responsibility is to take care of the fact that we actually decrease the burden of sickle cell disease in the community. So if we have to decrease the burden, we need to go ahead with newborn screening, identify affected newborns or individuals early on in life, and start treatment initiatives, vaccination, hydroxyurea before these children become symptomatic, to give them a good quality of life. And then newborn screening paves the way for prenatal diagnosis as well. You diagnose one child in a family who is suffering from that disorder. The parents know the ordeal what the patient or the child has to go through, and they are more receptive and more willing towards going ahead for prenatal diagnosis. So that is why the role of newborn screening is not only for that individual per se, but actually reducing the burden of sickle cell disease, going ahead with prenatal diagnosis. So you cannot go ahead with a roadmap for sickle cell without newborn screening.
And what iron supplement is given in pregnancy for the patient with SE?
Biological changes. There is much support is needed than the normal pregnant woman in disease cases. And regarding the hydroxyurea, some clinical trials had not been done prior for the use of the hydroxyurea during the pregnancy. Although there are some case reports who shows the inconsistent results. Some says the hydroxyurea is not teratogenic or is safe in certain cases, but in certain cases the deformities or stillbirth is high in pregnant women taking the hydroxyurea. So as far as no consistent results is there, but however, as per the previous recommendations that the hydroxyurea should be stopped before the 3 months before the planning of the pregnancy. Now, due to certain evidence, it is recommended that the hydroxyurea can be continue till the conceive of the pregnancy, and when the pregnancy is conceived, the hydroxyurea can be stopped during the pregnancy. And if the crisis is continue or there is increase in VOC, the hydroxyurea can be given after the third trimester in certain cases depending upon the severity of the sickle cell disease. Further, the second about the iron, as we all know, the iron requirement is very high during the pregnancy in normal women also. In sickle cell disease who are not transfusion dependent, also we have seen studies previously that 60% of the sickle cell disease patients themselves have iron deficiency. So without giving and benefiting with the iron supplement, there will be another different problems for sickle cell disease, suffering from sickle cell disease, iron deficiency itself, and this pregnancy. So we should monitor the iron level first at the time of the conception of the pregnancy, and the routine management of the iron supplementation should be given, which is recommended in normal pregnancy. So the sickle cell disease patient when there is no iron overload is there. Thanks.
So he has a wide experience in tribal areas. So to you, you have done an incredible work, and we would like to know how best sickle cell disease can be managed in tribal or rural settings of India. What best can be done? Could you throw some light?
Yeah, sure. Thank you.
Around 2.8 लाख लोगों की स्क्रीनिंग की और उसमें हमें 2600 सिकल सेल एसएस केसेस मिले, मोर देन 27,000 एएस केसेस मिले। उसमें हमने टारगेट बेस्ड पॉपुलेशन स्क्रीनिंग यूज़ की थी, क्योंकि ट्राइबल एरियाज भी हैं और एकदम रिमोटेस्ट एरियाज है इस स्टेट के, हम ये कहेंगे। तो वहाँ से हमें काफ़ी सारी लर्निंग्स मिली, स्पेशली जब हम स्क्रीनिंग करने जाते हैं तब बहुत सारे मिथ्स होते हैं उनके, कि कई सारी बहुत गलत इन्फॉर्मेशन भी उनके बीच में मिस इन्फॉर्मेशन है कि ये पाकिस्तान से आए हैं, वैक्सीन गलत HIV की इन्फेक्शन हमें डाल देंगे। ऐसी कई सारी चीज़ें होती जो हमें स्क्रीनिंग में हिंड्रेंस बन सकती है। लेकिन जैसे पंकज ने बोला था कि हम कम्युनिटी मीटिंग्स पहले करें तो स्क्रीनिंग में सपोर्ट मिल सकता है। तो मैं मैनेजमेंट पे, क्योंकि हम तभी आएंगे जब हम स्क्रीनिंग और डायग्नोसिस अच्छे से कर सकते हैं, क्योंकि कॉम्प्रिहेंसिव मैनेजमेंट की जब हम बात करते हैं तो उसमें काफ़ी सारे कंपोनेंट्स हैं। शायद अभी तक हमने मोन्था सर के अलावा उस पर डिस्कशंस नहीं कर पाए हैं कि स्क्रीनिंग होगी, डायग्नोसिस एंड अवेयरनेस, पब्लिक हेल्थ सिस्टम को भी हमें स्ट्रेंथन करने की जरूरत है। जो हम सब जानते हैं कि स्पेशली जो रिमोटेस्ट एरियाज हैं, जो इन सेटिंग्स की हम बात कर रहे हैं ट्राइबल्स की और इंडियन सेटिंग्स में भी हम देख रहे हैं कि पब्लिक हेल्थ सिस्टम अभी भी बहुत इम्प्रूव करने की जरूरत है, जो हमारा सिस्टम ऑलरेडी ट्राई कर रहा है। और हम ये कहेंगे कि सिस्टम काफ़ी हद तक सक्सेसफुल भी है, लेकिन उसमें फिर हम यहाँ आ जाते हैं कि जो रिमोट एरियाज है, जैसे अनंतपुर में कुशलागेट की स्पेसिफिकली बात करते हैं, डिंडोरी की बात करते हैं, वहाँ पर एक पूरा ब्लॉक है जो आधा डिस्ट्रिक्ट के बराबर है, जिसकी पॉपुलेशन 2,51,000 है। उस पूरे ब्लॉक पे सिर्फ 5 डॉक्टर्स हैं। पोस्टिंग होनी चाहिए थी बहुत सारे लोगों की, लेकिन सिर्फ 5 ही वहाँ पर पोस्टेड है। 5 में से 2 ही डॉक्टर परमानेंट है, उसमें से 1 ब्लॉक मेडिकल ऑफिसर है, बाकी सारे जो बॉन्ड पे आए हुए हैं। इतनी बड़ी पॉपुलेशन हमारे पास अभी फिलहाल 550 से ज़्यादा सिकल सेल के एसएस केसेस है। उनको हाइड्रोक्सीरिया पहुँचा भी दें हम PHC CHC, हम लोग काफ़ी कोशिश की, पहुँच भी जाती हैं, लेकिन प्रेस्क्राइब करने के लिए कौन? तो ऐसे में मतलब मैं सिर्फ क्रिटिसाइज नहीं कर रहा हूँ, इसके साथ सजेशन भी है हमारा कि हम क्योंकि डॉक्टर्स की क्राइसिस है जो इन एरियाज में काम कर सके, सिटीज में सब लोग आके काम कर सकते हैं, करना भी चाहते हैं, लेकिन हमारे पास नया कैडर भी है CHOs, जिसके बारे में हम सुबह से बात भी कर रहे हैं। उनको हम सिकल सेल पर डेफिनेटली हमें ट्रेनिंग करनी चाहिए, नॉट ओनली फॉर प्रिस्क्राइबिंग हाइड्रोक्सीरिया बट प्राइमरी लेवल की जो केयर है वो हम इन एरियाज में CHOs के थ्रू करवाई जा सकती है। और हमने रिसेंट में करके भी देखी है, हमने हमारे 75 6 CHOs है, उनकी भी हम ट्रेनिंग्स JSS के पायलट की तरह ट्रेनिंग्स किए थे, उसके आउटकम्स आने लगे हैं। अभी ज़्यादा आउटकम्स नहीं आए, ज़्यादा टाइम हुआ नहीं है अभी, लेकिन एक ये चीज़ की जा सकती है कि प्राइमरी लेवल की केयर, पेन मैनेजमेंट है या कॉम्प्लिकेशंस की स्क्रीनिंग्स हैं, वो CHOs के थ्रू करवाई जा सकती है। डेफिनेटली वो इन एरियाज में पेशेंट्स की लाइफ की क्वालिटी ऑफ लाइफ इंप्रूव करने में बहुत हेल्प करेगा। इसके साथ में क्योंकि ये पेशेंट्स जो होते हैं उनको हम अवेयरनेस की बात करें, लेकिन अवेयरनेस सिर्फ कुछ पोस्टर से या फिर 1-2 वीडियो दिखाने से तो नहीं आएगी। हम जानते हैं उनके साथ बार बार हमें मिलना पड़ेगा, और मैनेजमेंट में अवेयरनेस बहुत बड़ा रोल प्ले करती है। पेशेंट खुद सेल्फ अवेयर हो। तो 2017 में जब हमने काम शुरू किया था तो पहला हमारा मोटिव ये था कि पेशेंट को हम सेल्फ अवेयर इतना बनाएं कि वो खुद से मैनेज कर सके। बहुत सारे पेशेंट्स अभी हमारे बीच में ऐसे हैं जो खुद से आकर के दूसरे पेशेंट्स को लेके भी आते हैं, उनको बताते भी क्या करना है क्या नहीं करना है, हाइड्रोक्सीरिया लेती रहनी है। और ये सब पॉसिबल हो पाया पेशेंट सपोर्ट ग्रुप्स, जिनके लिए मैम ने बोला था कि केरला में हो रहे थे, यहाँ पे हमें करना चाहिए। मैम हम हर महीने 15 पेशेंट सपोर्ट ग्रुप मीटिंग्स इन 2 डिस्ट्रिक्ट्स में करते हैं। एक साल में करीब 180 पेशेंट सपोर्ट ग्रुप मीटिंग्स हमारी हो रही है काफी टाइम से। तो उसके आउटकम्स बहुत अच्छे निकल करके आए हैं। पेशेंट्स के जो नंबर ऑफ पेन क्राइसिस है, उनका कॉम्प्लायंस है हाइड्रोक्सीरिया के लिए वो बढ़ गया है। और पेशेंट सपोर्ट ग्रुप मीटिंग इन सेटिंग्स बहुत इंपॉर्टेंट हो जाता है, क्योंकि वो लोग पेशेंट्स इतने अवेयर नहीं है। और जब बार बार हम उनको मंथली या रेगुलर 3 मंथली भी फ्रीक्वेंसी रखी जा सकती है उसके लिए, उसमें पेशेंट अपने आप सेल्फ अवेयर होने लगता है। क्योंकि हम इसमें एक कंपोनेंट ये भी रखते हैं कि पेशेंट ऐसे सर्किल में बैठे और एक दूसरे के साथ इंटरेक्शन करें, अपनी स्टोरीज शेयर करते हैं। और स्टोरी जब एक पर्सन शेयर करता है तो दूसरे पर्सन को वो शक्ति देता है कि मैं भी कर सकता हूँ। और ये बहुत बड़ा रामबाण का साबित हुआ है हमारे। हम ये डेफिनेटली मतलब कह भी सकते हैं। रिसेंट में हमने एक चीज फिर पब्लिश की, ICMR में पेपर भी अप्रूव हो गया है रिसेंट, जल्दी ही वो पब्लिश होने वाला है। और नेक्स्ट एक चीज मैं ऐड करना चाहूँगा, टाइम की कमी है इसलिए मैं सिर्फ एक लास्ट पॉइंट बोलना चाहूँगा कि जो काउंसलर्स का रोल है वो काफ़ी इम्पोर्टेंट है। ये सभी समझते भी जानते भी, लेकिन हमने किया है। हमारे साथ आज यहाँ 3 काउंसलर्स मौजूद भी है जो हमारी टीम से आए हुए हैं, जो हमको डिलीवरी में काम करते हैं। ये पेशेंट्स को हॉस्पिटलाइज पेशेंट्स जो होते हैं उनमें भी कोऑर्डिनेशन लगता है, भले वो गवर्नमेंट हॉस्पिटल या फिर प्राइवेट में कहीं भी पहुँच गए। प्राइवेट में फिर भी ज़्यादा उनकी केयर होती है, लेकिन अपने DH में CHC में इतने ज़्यादा फॉलोअप नहीं हो पाते बिकॉज ऑफ लोड। तो काउंसलर्स उनको सपोर्ट करते हैं। उनके जब भी उनको इमरजेंसी होती है काउंसलर को फोन भी करते हैं। तो हमने एक हेल्पलाइन नंबर भी रिलीज किया, तो वो हेल्पलाइन नंबर स्टेट वाइड भी होना चाहिए जिसके मल्टीपल लोग उसको अटेंड करें, प्रॉपर इंफॉर्मेशन टाइमली दे पाएँ। तो हमारे जो काउंसलर्स है वो ये काम करते हैं, तुरंत उनको एम्बुलेंस की सुविधा भी उपलब्ध करवा दें। भले वो 108 की होती है या फिर परिवार एजुकेशन ऐसी कई सारी और संस्थाएं चला रही है उसके। तो काउंसलर्स को हमें सिस्टम में जरूर लाना चाहिए, जो हम रूबी मैम से भी पहले रिक्वेस्ट किए हैं, वो उस लाइन में भी हैं, उन्होंने बोला प्रपोजल भी दिया हुआ है, बट ये हमारे रोड मैप में जरूर होनी चाहिए। थैंक यू।
I would like to request Govt. Babu sir to throw some light on capacity building and how NHM can adapt this all over the state and all over India.
Once we move forward, definitely we have to have the health system's capacity that has to be improved. Okay, without that it can't be done. Because though there are different opinions that it is not only limited to tribal areas or tribal populations or commuter cities and all, these kind of arguments won't stand. Capacity building has to be done, right? Because we have greater experiences. India has the experience of managing COVID. Right? What else you can do? But the only thing is the government should ready for that one.
One suggestion I would like to give to NHM or what we can explore together is that if we can make use of these volunteers who are managing or running these support groups and use telemedicine or telehealth facilities in collaboration with all our medical colleges, wherein these volunteers can be roped in, not the actual patient, but they can identify the cases, they can identify the patients who might need medical advice where a doctor is not available, as an option to actually provide primary facilities. Like if only prescribing hydroxyurea is the problem because of non-availability, if a patient is not suffering from any acute complication, that prescription on telemedicine itself can be done. Okay. So we can explore this option of telehealth network also to reduce this complication and the dearth of availability of medical health professionals in remote areas using these volunteers.
We have to realize that very few number of sickle cell disease patients need such kind of consultations.
Yes.
CHO is also able to do, our PSC medical officer is able to manage these conditions up to 90% of the patients.
With your experience, what further research to be done and what should be the role of NHM in trials of new drugs, bone marrow transplantation, and also in financial assistance to the sickle cell disease patients? Over to you, sir.
I can't have the courage to advise NHM. I can only propose things. But I think the reason issues and lacunae that we need to look at was the fact that I was supposed to speak on, what research should be carried on. So you are already familiar with, what are the areas that we probably need to work on. And clearly this goes into two aspects. One is always with the focus on the patients largely. But then other one will be that where you just want to understand some basic mechanisms, because anything basic done is always, gives its fruits several years or decades later, but that shouldn't take away. Say for example, just one I would like to give, that we all know that our clinical phenotype is mild, and it is, as far as I understand, it is ascribed to the high fetal hemoglobin levels. One of the major reasons is that there are others also. And but today, we are in an era where there are about 40 or 50 such genes which are known to influence the fetal hemoglobin levels. But there isn't any specific effort that goes on. And as far as I understand, that fetal hemoglobin is one thing that is available on every patient, multiple times also probably. So I think this is one of the things where the groups can come together with their data sets, fetal hemoglobin, and try to identify, have a bit better understanding of, like a genetic study can be done on that. Second is that when we already have high fetal hemoglobin, then what's the point of giving hydroxyurea? Like elsewhere it is 5%, 6%, it increases by a few more percent, but then
level. It doesn't work on VOC, pain. While glutamine is said to deplete the VOC episodes. The glutamine available in India is, we use for malnourished children as supplement, even in pregnancy they use as nutritional supplement. So I have been using this off-label glutamine in patients who are not responding to hydroxyurea with the available sachets, glutamine, and they are like working well. But there are no clinical trials, and there need to be a trial on voxelotor and glutamine in our country, which has not yet been started. I think you can tell more about glutamine. There is a trial in pipeline, and maybe within 6 months we should be able to start. Yes. Okay. The other thing was about bone marrow transplant.
Yeah, bone marrow transplantation,
Yeah, what we should do is, I think, I never did that before because I thought my patients can't afford bone marrow, so I will not do. Let us screen the sibling and the relatives of severe patients with sickle cell disease for HLA typing. And try to do that before. If you have to do bone marrow transplant stem cell, you should do before 15, 12 years. The results are best with that and in the sibling. So now all my severe patients have their HLA typing. The family HLA typing has been done, and I have 5 patients who are ready for bone marrow with HLA typing matched sibling. So they can be having good results. So I think that is one thing. And about the cost, this Ruby will be able to tell us. I think in this mission project, sickle cell project, there are funds for bone marrow transplant in.
I mean, at least I have got the information that sickle cell anemia and sickle cell disease are 2 different entities. Sickle cell anemia is included in sickle cell disease. So, something that I wasn't aware for a long time, but then as an experience in this, I understand that there are at least 10 to 12% of these so-called sickle cell patients who are sickle cell disease. And again, please correct me if I am wrong, but there is no screening test which actually can confirm that there is a sickle cell disease. So this is another topic of research, and that is where the technology which I was mentioning, that we can just use a small drop of blood. We have now developed a test for 5 common mutations which cater to about 90 to 93% of beta thalassemia cases also. But again, the problem is that how do you screen them first to suggest that these subjects need to, go for this kind of a PCR test. So I'm not sure what strategy can be there, but I have consulted with many people who have worked with HPLC and others, but these are all largely indicative, and many of these results have, not come out to be, what they are supposed to be. And one more thing, okay, I'll tell at the end maybe. Oh, I can just finish it up. Okay. So this is for NASCO actually. I think, this is, again, please don't take it as a criticism, or even if criticism, a positive criticism. So I think this is the third meeting that is happening in 3 states, and probably 3 people are definitely common other than the NASCO people. Me, Dr. Patra and Dipti Jain. Well, I must admire, NASCO's efforts in making us aware and making us, interact with you people and everybody. But honestly speaking, I don't see any headway. I think the first meeting was somewhere in June or July. Then one was in October, and then this other one is there. I'm just suggesting this that I've been saying that there should be some minutes of the meeting, some action points which should be there, and let every meeting that we conduct at another state, let those minutes of the meeting or the points from there be shared. I'm sorry, but many of the points are actually repetitive. I mean, everybody knows about various things. So if we can, Mr. Gautam did a good job of trying to set up the context, but it may be a good idea to, start with that. We have had 2-3 meetings, and these are the things that everybody is aware what we need to do for career and other. I think that it will probably maybe a little more focused, and since 3 meetings have taken place from 3 states, whether we can have some sort of a white paper or recommendation or something. I think that if we start taking some baby steps, probably, these efforts will become really, and once you advertise, then there might be more people coming into this on their own volition, that they have their ideas also. So apologies if I have hurt anywhere or so, but I just thought that to speak with open mind and see that how we all can contribute.
Advise your advisors. सिर्फ नाम के लिए आप बना के मत रखिए, उनको परेशान कीजिए थोड़ा.
Yeah, thank you so much, sir. Jai sir.
Thank you so much, sir.
We will take the opportunity to do this for an MP.
Oh yes.
This panel discussion, and thank you all eminent panelists for participating. We learned a lot too from this panel discussion. Now I would like to invite Dr. Ruby Khan ma'am. Ma'am is Deputy Director, State Hemoglobinopathy Mission, NHM, Madhya Pradesh. Ma'am is going to give us closing address.
So there are few patients and few people who want to just say a few things. Yes sir.
वो जैसे ही ठीक हुआ, और मुझे बस नेक्स्ट डे भोपाल के लिए आना था, आज यहाँ के लिए. तो मेरी बेटी सीरियल क्राइसिस में चली गई. अभी वो मेरी मिसेज ने उनको एडमिट कराया है. अब वो एडमिट है. कंडीशंस आपकी हमारी आज भी हुई है. आज मैं भी यहाँ पर हूँ, लेकिन मेरा पूरा हार्ट अभी मेरी मिसेज कैसे हैंडल कर रही होगी, और मेरी बच्ची अभी 7 पॉइंट पर है, वो कैसे कर रही होगी. जीएमसी में अब मेरी मिसेज अकेला है, और रात को उसको भर्ती करना पड़ेगा, मैसेज आया है. बट ये बिल्कुल सही है आपका, और ये स्थिति को ही हमको कम करना है, इसलिए हम लोग आज
सर नाउ यू मोटिवेट में हमें बोल सकते हैं. हम लोगों को लेके भागते थे साइकिल में, डॉक्टर ने वोगोरन का इंजेक्शन दिया, दर्द ठीक हो गया. फिर हुआ, दर्द ठीक हो गया, वोगोरन की मेडिसिन खाई, ठीक हो गया. पर किसी डॉक्टर ने ये नहीं बोला कि सिकलिंग टेस्ट करा लो. क्यों नहीं बोला ऐसा? सीवियर जो क्रॉनिक पेन है वो तो है ही है, पर किसी ने क्यों डॉक्टर ने नहीं बोला कि ये आप इसका टेस्ट करा लो. आज हम यहाँ अवेयरनेस की बात कर रहे हैं. सर आई एम वेल एजुकेटेड. आई हैव डन बीएससी, एमएससी इन फिजिक्स, एमए इन हिंदी लिटरेचर, एमबीए इन फाइनेंस. माय फादर मदर इज आल्सो वेल एजुकेटेड. दे हैव आल्सो डन पोस्ट ग्रेजुएट एट दैट टाइम. बट हम अवेयरनेस की बात कर रहे हैं. मेरे फादर ले गए इंदौर मेरे ब्रदर को, उन्होंने बोला आप एक्सरसाइज कर लीजिए, थोड़ा सा फिजियोथेरेपी बताया, ठीक हो जाएंगे, कोई इशू नहीं है. इंदौर में भी किसी ने नहीं बताया कि सिकलिंग टेस्ट करा लो. किसी ने नहीं बोला. अवेयरनेस. अवेयरनेस, मुझे पानी पीने की अवेयरनेस आज 40 इयर्स में आ रही है। आज मुझे पता चल रहा कि ये रामबाण है मेरे लिए, ये सिकल सेल वॉरियर के लिए रामबाण है। जो हनुमान जी ने अपने लक्ष्मण के लिए लेके आए थे ना, जन्म जड़ी बूटी, जो ये मेरे लिए वो रामबाण है। पानी किसी ने नहीं बताया मुझे, पहले बचपन से क्यों नहीं बताया मुझे? शायद मेरी इतनी सारी कॉम्प्लिकेशन नहीं होता अगर मैं पानी पीता खूब ज्यादा तो, पर किसी ने नहीं बताया, किसी ने नहीं बोला। हाँ, कुछ डॉक्टरों ने बोला कि सिकलिन टेस्ट करा लो, कराया, सिकलिन टेस्ट भी कराया, पर नेगेटिव हो गया। कैसे? ये तो जेनेटिक डिसीज है। उस समय कैसे नेगेटिव हो गया और अब मैं पॉजिटिव हो गया? वाओ, इट्स वंडर, मेरे लिए तो वंडर है। सॉरी अगर सर, मैं सबसे पहले क्षमा मांगना चाहूँगा, मैं किसी को हर्ट नहीं करना चाहता, लेकिन मैं अपनी ये स्टोरी इसलिए बताना चाह रहा था आप लोगों को कि मैंने फर्स्ट टाइम जब टेस्ट कराया था तो नेगेटिव आया था सिकल सेल। जेनेटिक डिसीज है तो ये तो बचपन से पैदा होने के साथ ही मेरे साथ आ गई ना, ये तो फिर कैसे नेगेटिव हो गई? हाइड्रोक्सीयूरिया का मुझे तो तब पता चला जब मैं सीवियर कंडीशन में पहुंच गया, एक्यूट सिंड्रोम चेस्ट के कारण। मैं यहाँ एसबीआई में पोस्टेड हूँ, उस समय मैं सागर में पोस्टेड था। रात को 12 बजे मुझे एक्यूट चेस्ट सिंड्रोम का अटैक आया और मुझे डायरेक्टली यहाँ पे भोपाल लाया गया और आईसीयू में भर्ती कर दिया गया। आई एम वेरी थैंकफुल टू गॉड फादर मिस्टर एनपी मिश्रा, जो इस समय नहीं रहे अभी। उन्होंने मुझे सीवियर कंडीशन से निकाला। उन्होंने सबसे पहले मुझे दिया हाइड्रोक्सीयूरिया, सबसे पहला डोज मेरे को हाइड्रोक्सीयूरिया 4 साल पहले मिला। शायद पहले मिल जाता तो मुझे शायद इतनी तकलीफ ना झेलना पड़ता। हम किस सर ड्रग्स की अवेलेबिलिटी बात कर रहे हैं हम। 150-130 रुपए की हाइड्रोक्सीयूरिया आती है 10 टैबलेट्स, मतलब 13 रुपए की एक टैबलेट। मैं सक्षम हूँ क्यों? क्योंकि मुझे रिएम्बर्समेंट हो जाता है बैंक से। लेकिन वो गरीब लोग क्या 13 रुपए की एक गोली खा सकते हैं? जिनके पास एक टाइम के खाने के लिए पैसा नहीं होता, खा सकते हैं? नहीं। तो इस गोली को इतना महंगा क्यों बना रहे हैं? ठीक है, सरकारी हॉस्पिटल में अवेलेबल है, पर कितनी अवेलेबल है सर? यहीं पर मुझे सर किसी ने बोला था कि आप सरकारी हॉस्पिटल से ले लिया करें। मैंने बोला नहीं, मुझे तो उसका रिएम्बर्स हो जाता है तो मैं अपना खरीद के ले लूंगा, पर जो मेरी मेडिसिन बच जाएगी वो किसी गरीब को सरकारी हॉस्पिटल से मिल जाएगी।
Conference, and there are a lot of learning and takeaways from this conference, and I can assure that NHM MP is always welcomes all kind of suggestions, recommendations from the expert and delegates, and I'm really thankful to all of you कि आप लोगों ने अपने इतने कीमती समय में हमारे लिए समय निकाला, हमें एक रोड मैप देने के लिए। एंड मैं सबसे पहले अपने मुझे नहीं पता था जब मुझे ये प्रोग्राम मिला सिकल सेल, एक्चुअली आई एम अ पैथोलॉजिस्ट, तो आई वाज लुकिंग द लैब सर्विसेज एंड ब्लड सर्विसेज। जब सिकल सेल देखना मैंने शुरू किया और जब मैं एनएचएम में आ गई, एक्चुअली प्रीवियसली आई वाज सिटिंग इन द डायरेक्टरेट ऑफ ब्लड सर्विसेज, देन आई केम टू नो कि मेरे एनएचएम के ऑफिस में भी 2 वॉरियर हैं, वन इज कौशल्या एंड वन इज मानसिंह।
हो गया, देन दे केम टू मी कि मैम हमारी फैमिली में भी ऐसा है या वो, एंड दे आर लाइक इतने पॉजिटिव लोग हैं ये लोग कि मतलब इनको कभी जाते हैं हॉस्पिटल में कोई रिस्पांस नहीं मिलता। शी बिलोंग टू वन ट्रैवल विलेज, वी आल्सो बिलोंग टू डिंडोरी, तो इसको यहाँ अगर दवा नहीं मिलती, प्रॉब्लम तो नहीं है। तब इन लोगों ने मुझे बताया कि हाँ ऐसा यहाँ हो रहा है, देन वी स्टार्टेड डूइंग थिंग्स। सेम मानसिंह बहुत ही अच्छी इसकी फैमिली है, इसके बच्चे हैं, दोनों हस्बैंड वाइफ कैरियर हैं, इनकी बेटी को डिसीज है एंड छोटा बच्चा है। इसकी पूरी फैमिली, जब इसको पता चला तो इसने पूरी अपनी फैमिली को स्क्रीन कराया और अब ये सारी अवेयरनेस अपने सारे रिश्तेदारों को, सिबलिंग्स को, जो भी फैमिली में है सबको बता रहा है एंड बोथ आर वेरी सपोर्टिव। इवन अब ये चीज़ मतलब ये सबको बताते हैं और आई एम वेरी हैप्पी कि इन लोगों की वजह से जब भी मुझे लगता है कि हाँ आई फील like inspiration, I ask them to come to my chamber and just talk to me. मेरे लिए आई एम रियली थैंकफुल कि आप लोगों ने यहाँ पे आए और हम बहुत सारी चीज़ें करना चाहते हैं। देयर आर लॉट ऑफ लर्निंग्स, आई रियली फील दैट कि कुछ चीज़ें डिस्कशन में आई, बहुत जैसे सपोर्ट ग्रुप का पहले भी हम लोग डॉक्टर पंकज से डिस्कस करते थे एंड इसीलिए हमने अपनी एक अलग से मध्य प्रदेश के लिए ट्रीटमेंट गाइडलाइन हमने खुद बनाई है। वेरी सून वी आर गोइंग टू लॉन्च इट, जिसमें एक पूरा चैप्टर है जिसमें हम पेशेंट सपोर्ट ग्रुप के लिए रख रहे हैं सेम उसी तरह जैसे मैम ने कहा कि हाइड्रोक्सी यूरिया फॉर डिफरेंट काइंड ऑफ एज ग्रुप के, अगर पेशेंट के लिए अगर पीडियाट्रिक है तो उसके लिए क्या होगा, अगर प्रेग्नेंट वुमेन है तो उसका ट्रीटमेंट, तो एक कम्प्रिहेंसिव ट्रीटमेंट कैसे होगा, उसका पूरा गाइडलाइन वी हैड प्रिपेयर्ड विद द हेल्प ऑफ एक्सपर्ट्स फ्रॉम ICMR, फ्रॉम एम्स, फ्रॉम GMC. So I think it will help us, and always like I always welcome you all कि आप लोग मुझे बताएं. We are
I would like to invite Parikipata Shridev ma'am to felicitate Dr. Shweta Sharma ma'am. I would like to invite Ms. Salu Nas to felicitate Dr. I would like to invite Roshni to felicitate Dr. Now we are going to
अभी NHM और NASCO का भी सर्जन उससे पहले पूछना चाहिए कि मैम प्रियंका दास मैडम जो मिशन डायरेक्टर NHM उन्होंने अपना कीमती समय निकाला इस कॉन्फ्रेंस के लिए और सबको अपना सहयोग दिया कि सुविधाएं जो फैसिलिटीज इस कॉन्फ्रेंस को हम करा सकें यहाँ पे भोपाल में. तो बिग थैंक्स टू मैम एंड जो उन्होंने काफ़ी अच्छे से सुना और जो समझा. मुझे उम्मीद है कि वो पेशेंट सपोर्ट ग्रुप जो उन्होंने एम्फेसिस किया और जो यूनिफॉर्म स्क्रीनिंग मॉडल होना चाहिए, अपार्ट फ्रॉम द ट्राइबल ग्रुप्स द स्क्रीनिंग शुड बी डन टू द अदर कम्युनिटी पर्सन, तो वो आगे आके लेके जाएंगे. तो मेरी उनसे उम्मीद है काफ़ी ताकि ये सिकल सेल डिजीज एलिमिनेशन प्रोग्राम में सपोर्ट हो सके. तो तहे दिल से मैं शुक्र करना चाहूँगा. उसके बाद मैं किसी मैम करते हैं जो इतना दूर से यहाँ पे आए और इतने सारे अच्छे सजेशन दिए रिगार्डिंग दी वैक्सीनेशन, रिगार्डिंग दी बोन ट्रांसप्लांटेशन, रिगार्डिंग दी न्यू ड्रग्स जितने भी आ रही हैं. और दूसरा कि जो नेशनल प्रोग्राम्स के बारे में मैडम ने बताया कि जैसे मैडम ने एक दिन काफ़ी प्यारी मीटिंग मैडम के साथ मेरी खुद की भी हुई हैं. तो काफ़ी सारा मतलब मैं रात 10 बजे तक भी मीटिंग हम लोग की होती थी. तो काफ़ी सपोर्ट मैडम का रहा है इस प्रोग्राम को आगे ले जाने के लिए. मैं और आशा करता हूँ कि मैडम काफ़ी इस प्रोग्राम को अच्छे से और जो सपोर्ट हम लोग को चाहिए वो आगे देते रहेंगे. बिग थैंक्स टू मैम. सेकेंडली फिर गौता बाबू सर का जो ICMR हेडक्वार्टर से आए और उन्होंने इम्प्लीमेंटेशन रिसर्च के बारे में बात करें कि जो सिकल सेल डिजीज के ऊपर होना चाहिए ताकि हम जितने भी गैप्स हैं उनको आइडेंटिफाई कर सकें डिजीज के लिए, चाहे वैक्सीनेशन हो, चाहे ब्लड ट्रांसप्लांट हो, चाहे अवेयरनेस के लिए जो इम्प्लीमेंटेशन गैप्स है उसको नीड को स्टडी है उन्होंने हाईलाइट किया बहुत अच्छे से. तो गौता बाबू सर को थैंक्स बोलना चाहूँगा. काफ़ी हैदराबाद से चले हैं और ये NASCO के हमेशा से और सिकल सेल के लिए नेशनल प्रोग्राम में भी का जो सिकल सेल के लिए की जो भूमिका है काफ़ी सराहनीय है. और आशा करते हैं जो इन्होंने जो काफ़ी जो नोबल आइडियाज़ दिए कि सारे डेटा को सेंटर को कोलैबोरेट करके उसके डाटा को एनालाइज करना वो बहुत इम्पोर्टेंट है. तो जो भी सर हम लोग की तरफ से सपोर्ट लगेगा और जो भी हम लोग की तरफ से और आपसे सपोर्ट हमेशा उम्मीद रखेंगे कि इसमें हम आगे कैसे हम इसको लेके जाएं.
भागना नहीं, लेकिन उम्मीद रखो कि भागना नहीं.
भागते नहीं हम सर
मतलब उम्मीद रखियो, उम्मीद हम पूरे करेंगे और तुम भी करोगे.
मिल के करेंगे. मैं थैंक यू बोलूँगा पात्रा सर का जो फ्लाइट ले होते हैं कैंसिल के बाद भी आए. उन्होंने अपने छत्तीसगढ़ के जो एक्सपीरियंसेस बताए जबकि शुरुआत जो स्क्रीनिंग प्रोग्राम की हुई थी जो इनिशियली वो छत्तीसगढ़ और गुजरात 2 स्टेट्स में सबसे पहले शुरू हुई और उनका जो सिकल सेल को इस मिशन में लेकर आने का जो अभी तक है कि मिशन के रूप में वो लॉन्च हो गया. तो डॉक्टर सर के लिए बिग थैंक्स. And second, then I thank to all and they understand that how the disease can be managed and they can be a role model for other sickle cell disease patients and the stories of these patients can be highlighted on the national program as well. So that when we see before I think that for promoting the blood transfusion practices national television advertisement was coming that I have a thalassemia. Thanks to all. So certain types of this advertisements or social messages in today's through these sickle cell warriors, and I need support from that also. You also. And lastly, but not the least, I wholeheartedly thank to Gautam ji who organized this conference very well and in a very short time of his span. And I hope this as this conductor that the minutes of the meetings of the conference should be recorded, and what are the action taken plan should be taken forward to the NHM, not only the Madhya Pradesh but also the Government of India, so that the roadmap can be strengthened for the hurdles which are a sickle cell disease elimination program can be removed. So I thank you all, and I thank also these photographers and the auditorium management team and all the other things who successfully helping in throughout this conference. Thank you all.
की इस कार्यक्रम को सक्सेस बनाने के लिए मैं भी नेशनल अलायंस सिकल सेल ऑर्गेनाइजेशन की तरफ से आप सभी को बहुत बहुत धन्यवाद देता हूँ कि आप लोगों ने रिक्वेस्ट को मान दिया और आप लोग यहाँ तक आए, तकलीफों से आए, और शब्द नहीं है हमारे पास। तो भारत के सभी सिकल सेल पीड़ितों की तरफ से आप सभी एक्सपर्ट्स को बहुत बहुत धन्यवाद। आपके शब्दों से किसी का जीवन सुधरने वाला है, वो कुछ खुशियों के दिन देखने वाला है। बहुत बहुत धन्यवाद। और इस कार्यक्रम को सक्सेस बनाने के लिए हमारी टीम, रुचिता जी आप सभी थोड़ा सा खड़े हो जाए, मैं आपको इंट्रोडक्शन कर दूं। रुचिता जी सिकल सेल वॉरियर मध्य प्रदेश, स्नेहा सिकल सेल वॉरियर छत्तीसगढ़, मिस्टर ललित पारगी सिकल सेल वॉरियर फ्रॉम राजस्थान, और इसके अलावा भी आइए अलीम जी, निशांत वासी जी, एंड ऑल्सो वेरी सर्कल Mukesh ji from Rajasthan and Sankalp Khobragade sir from Maharashtra. These all are the backbones for the event, and that is why we could success this. ये सभी लोग सतत अपने पेन को, अपने तकलीफ को साइड में रख करके इस कार्यक्रम को सक्सेस बनाने के लिए दिन रात इन्होंने कम समय में काफी मेहनत की। तो आप लोगों की तरफ से आशीर्वाद चाहते हैं। ये कार्यक्रम और अभी भोजन की व्यवस्था है, आपको इसी टेबल पर भोजन की व्यवस्था होगी। कृपया सभी खाना खाकर ही विश्राम करें। बहुत बहुत धन्यवाद। रीइंवेस्टमेंट फॉर्म हमारे टेबल पर है, जिन्हें इसको फिलअप करना है, जिनको बताया गया है वो जरूर वो फॉर्म फिलअप करके सबमिट कर देंगे। हम कुछ ही दिनों में वो रीइंवेस्टमेंट फॉर्म कर देंगे। थैंक यू सो मच फॉर ऑल।